Okay, can we stand for the pledge? And Senator Prentice, can you lead us in the pledge?
Pledge allegiance to the flag of the United States of America, and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Well, welcome to Health and Human Services Senate Committee hearing, and happy Valentine's Day to everyone. And it's a good thing I didn't give up chocolate for Lent. So, we will, oh, thank you. We will open the hearing. Senate Bill 458, dispensing of certain medications, and welcome the prime sponsor, Senator Avard.
Thank you, Madam Chair. And as you can see, I have a red folder for Valentine's Day. Happy Valentine's Day.
You too.
And for the record, I am Senator Kevin Avard, representing District 12, and I am the prime sponsor. And as you can see, we have some wonderful prime sponsors or co-sponsors on this bill. And this bill basically adds to the list of exceptions to the prohibition of dealing in or possessing prescription drugs to the, let me reread that again. This bill adds to the list of exceptions to the prohibition for dealing in or possessing prescription drugs, the dispensing of up to 90 days supply of non-controlled oral anti-cancer medications by a licensed healthcare professional legally authorized to administer medications to a patient under the provider care provision. This legislation was brought forward on behalf of the Oncology and Hematology, which is a medical practices that specializes in treating patients suffering from cancer. This legislation would allow the New Hampshire Oncology and Hematology to directly dispense a limited supply of non-controlled oral anti-cancer drugs to patients under their care. The practice took this issue to the Board of Pharmacy, and it ruled that they needed legislative clarity to allow the practice to directly dispense to their patients. 39 other states, including Massachusetts, Vermont, and Maine, allow for the direct dispensing of anti-cancer drugs from providers. This is enabling legislation. It does not place any new mandates on insurers, providers, or patients. Insurance companies can still require covered members to use preferred pharmacies and prior authorization. Direct dispensing of oral anti-cancer drugs is gaining popularity around the country and has many benefits for patients, including better care coordination, reduced time of diagnosis and treatment, and it lowers the barriers for medication uptake and adherence. I believe today Dr. Peter Crow from New Hampshire Oncology and Hematology is here to answer any questions that you may have regarding this bill. Very simple bill. And like I said, it's just enabling legislation. And that's about it.
Thank you, Senator. Any questions from the committee? Seeing none.
Thank you very much.
Representative Merchant. Welcome.
We're ready for Valentine's Day, right? Thank you, Madam Chairperson, and members of the Senate Health and Human Services Committee, along with members of the public. For the record, I am Representative Gary Merchant, representing Sullivan County District 6, Claremont and Croydon. I come before the committee to oppose the bill, but do support creating a study committee or interim study. Physician dispensing directly to patients from the office or clinic has potential dangers. While there are arguments both for and against this practice, it's important to consider the following risk. Patient safety. What I'm trying to get to here is that there's many studies out there that one of the biggest errors of medication errors themselves is prescribing. And by far, it's the leading cause of medication errors, which lead to hospitalizations. most of those are caught by a nurse or a pharmacist before they're dispensing the medication or before they administer the medication. There's a reference here to go back and look at this. If you look at the Community Oncology Alliance, in their own position statement, they talk about 400 errors that are caught by a pharmacist. I'm not opposed to a pharmacy inside of the clinic, but the double check, when I worked at the medical center, we had 2 sets of eyeballs to look at every single order from an oncologist. One was to ensure that the drug was appropriate, was correct, right strength, right dose, and so forth. We caught many times errors that were made. My concern with this here, there's no requirement for a pharmacist to do that check. Before it goes home to the patient, once the patient leaves and goes home and has a medication that's wrong, there's no calling it back. If you have 90 days, it's 90 days for a patient to go with a medication that's incorrect. So it's concern about patient safety. Patient cost. Many times with pharmacy networks, if you're outside of the network, if the clinic doesn't have a contract with a PBM, they may jeopardize the patient having a higher cost because the pharmacy or the clinic is outside of their network. So therefore, the costs are going to go up to the patient, which is a detriment to the patient themselves. Freedom of choice. We're a strong state. We believe in freedom of choice. And I think at this point in time, it could create unfair pressure onto a patient to utilize that dispensing functionality versus actually going to where they want to go. Maybe they want to go back to their own pharmacy for whatever reason. Conflict of interest. Physicians who dispense medications may have a financial incentive to prescribe certain drugs over other ones at a detriment to the patient. And also regulatory. When you have the dispensing, if it's not under the Board of Pharmacy, we're creating 2 standards of care in our state of New Hampshire. One for those who go to a pharmacy and one who don't go to a pharmacy. So what I'm concerned about is that the standard of care that we have today, which has worked very well, could be jeopardized. I'm not saying that we shouldn't look forward to trying to work on a solution, but I think we should find a way for us to collectively get together. I think it's called a Bradley Special, to bring people together in a collaborative manner, all the stakeholders, and try to find a way. FYI, there is another clinic in New Hampshire who does have a pharmacy license. And they were able to get one from the Board of Pharmacy. So there's no reason why this clinic couldn't also apply to the Board of Pharmacy to get one. I think what they applied for and how it was resolved was more the ask than it was what could be done. So I'm not in favor of the bill as written, but I would be more than glad to support a study committee or commission or an interim study to get the stakeholders together and talk about what we can do. We have to modify the pharmacy statutes to allow for a pharmacy within the clinic. If that's the barrier, then let's deal with that. But let's ensure that patient safety is first and foremost. And therefore, at this point in time, we're not jeopardizing that level of care.
Thank you, Representative. Any questions? Senator Avard.
Well, thank you. And from my understanding, there's 39 other states that are doing this. So is there a problem with the other 39 states that causing great alarm?
I think we'd have to look at, are we talking about a pharmacy within the clinic, and therefore they have a pharmacy permit? Even the Community Alliance for Oncology supports having a pharmacist within the clinic and having a pharmacy review. So the answer to your question, Senator Avard, that I don't know to what
Call
level.
me doctor if you like. May I follow up?
Please.
Thank you. Well, you know, one of the reasons I thought this might be a good idea, and of course I am not a pharmacist, but you know, supposing we have some kind of a natural disaster or something to that effect, and somebody that needs those prescriptions can't get it because we have a natural disaster or there's another outbreak, COVID or something to that effect. I'm looking out for I think I'm looking out for the patients with this bill, in that, you know, any way to simplify, you know, their access, to me makes sense. And this isn't a mandate; it's just enabling. And I believe that they went to the Board of Pharmacy, and they said, look, can we do this? And they said, well, there's a gray area. You need the legislation to clarify the language. But it's not like it's a mandate.
My underlying concern, again, goes back to patient safety. I've worked enough in hospitals, enough inside of community pharmacies as well. Medications, as one of my professors said to me, are poisons with therapeutic side effects. The only thing that separates a poison from a drug is the dose. So when you provide to a patient a dose that's not correct or a drug that's not correct, and you do it for 90 days, there are real safety issues. The double check, if you will, is so critical to what we're doing, because if you look at the overall process from the time you prescribe the drug to the time the patient takes it, there are several checks along the way before the patient actually gets it. The pharmacist reviews it, the nurse could review it, and those people are basically ensuring that, for the most part, if an error has been made, that they catch it before it gets to the patient.
Thank you. Move further.
Thanks.
Any other questions from the committee? Seeing none, thank you, Representative. Mike Rollo? Oh, you're right, sorry. Is it Dr. Peter Fro?
Sure.
Good morning, Madam Chairwoman, members of the committee. For the record, my name is Dr. Peter Crow. I'm an oncology hematology specialist at New Hampshire Oncology. New Hampshire Oncology Hematology is a medical practice consisting of more than 100 staff members, including 8 board certified and board eligible oncologists and hematologists, physician assistants, nurse practitioners, certified oncology nurses, clinical pharmacists, and pharmacy technicians. Our mission is to provide expert, compassionate medical care for adults with cancer and blood-related diseases. I appear to you today in support of Senate Bill 458, legislation that was requested by my organization. In order to explain the reasoning behind why we asked Senator Avard to file the bill, I'd like to step back and provide some background. In April of last year, 2023, New Hampshire Oncology requested a declaratory ruling from the New Hampshire Board of Pharmacy on whether physicians could dispense non-controlled prescription drugs in order to meet patients' immediate medical needs without limitation on days' supply except for what is clinically appropriate. I should say that this was a continuation of an ongoing discussion about this over the course of years, where we've talked with the Board of Pharmacy trying to clarify this issue. Ultimately, the board ruled that the request for ruling was outside of the board's jurisdiction and that they did not have authority to do so, which was up to the legislature to grant. Therefore, we're here today to ask your support to dispense up to a 90-day supply of non-controlled anti-cancer medications. Over the past decade, alternative anti-cancer medications, or oncolytics, have been brought to the market, replacing traditional intravenous therapies. The medications do not need to be mixed or compounded and are almost exclusively pills or tablets. The prescriptions free the patient from having to physically be in the clinic for treatment and instead allow them to manage their cancer treatments at home with proper monitoring by their providers. We have found through our practice that there are a number of clinical and convenience-based challenges with the specialty pharmacy dispensing process. Currently, patients must coordinate deliveries, which at times can be delayed, affecting a patient's clinical outcome. Also complicating the process is altering the dosages of medications for treatment. When this occurs, the adjustments necessitate new prescriptions, which can start the whole approval process again. That also often leads to delays and sometimes adjustments in patients. We have to sort of adjust things on the fly for patients, which undermines the effectiveness of the treatment. There are a few things that I request the committee to keep in mind when considering this legislation. Studies have shown that enabling licensed cancer healthcare professionals to dispense a long-term supply of non-controlled oral anti-cancer drugs above and beyond what is currently authorized will optimize a patient's adherence to their treatment, increase doctors' ability to personalize cancer treatments to best address patient needs, and streamline the order process for drugs needed for treatment. Research has also shown that patients served through a direct dispensing model, like we proposed, have a 95% medication adherence rate versus 70% when the prescriptions are dispensed through other means. This ultimately leads to better outcomes. Our facility has a licensed pharmacist on staff that will work in consultation with our practitioners to dispense the medications. Our clinic-based pharmacy currently adheres to all USP quality standards and is subject to inspection by the New Hampshire Board of Pharmacy. Finally, our patients are carefully and nearly continuously monitored, not only to develop a better understanding of their individualized needs and unique experiences, but to ensure their safety. If there are issues or changes to their status, we have the ability to quickly change the course of treatment, including the doses of their prescriptions. I want to make the committee aware that we understand that there are some concerns that will be articulated today regarding the bill as written, and we're committed to continuing the dialogue with folks to move this legislation forward. I'd also like to thank you for the opportunity to speak to you before you today, and would be happy to take any questions.
Senator Abar.
Thank you. And thank you for testifying. I believe you submitted this with the ruling with the board, which basically confirms the fact that they need the clarification on this bill. My question goes back to the previous speaker because he was concerned about safety and the stock gaps, if you will, with the nurses and others. And, he was okay with it being within a clinic scenario, but can you talk a little bit about the safety issue versus with the ruling of the board?
Yeah, so I think with the safety, it's easy to confuse issues related to the intravenous administration of chemotherapy drugs versus medicines like these that are done at home. So it's absolutely correct that in the office there are multiple different checks before a person gets their medication, including in our office. The pharmacist, another review of the medications is being prepared with the pharmacist and the pharm techs, the nurses, the physicians. There are multiple steps that we go through with intravenous administration of drugs. With oral drugs, the way things exist now is the prescriptions are prepared in a pharmacy and delivered to the patient, and nurses are not there to monitor that. The medicines are given at home. We have in our office, we have structures to call the patients and check compliance and see how things are going and to follow up on things. But it's a very different circumstance than you think about when we give the medicines in the office. We do have a pharmacist in our practice who would be overseeing this what we propose to do the dispensing of the home medication. So these would not be prescriptions that are going out without appropriate supervision. As a physician, as an oncologist, I am one of the my major focuses in treating patients with cancer is making sure that we're giving them medicines in a way that is as safe as possible. And we have many different structures in our office to ensure that, and we would absolutely apply those in this circumstance. But I think the general idea, the pharmacist would be overseeing the distribution of these medicines to the patients.
Thank you.
Great, thank you.
Henry Livman.
Madam Chair, I'm still not here yet. Can I defer a little bit longer if necessary? At the end.
Sure.
In favor.
Tanya Carlton.
Good morning. Dear Chairman Birdsall and committees, members of the committee. My name is Tanya Carlton. I've been a practicing pharmacist in the state of New Hampshire for over 20 years across multiple healthcare settings. I currently serve as the president of NHSHP, which is the New Hampshire Society of Health System Pharmacists, and I am here to testify for NHSHP in opposition to SB 458 as introduced. We are echoing concerns brought forth by Representative Merchant. I'll briefly summarize my testimony, but you all should have a copy in your hands. We understand the concept of this bill is to address delays in starting treatment, and we are concerned with some sections of the bill. Some questions and concerns are outlined below. First off, why can't New Hampshire Oncology and Hematology simply request a pharmacy license? The Community Oncology Alliance has a position statement encouraging dispensing of the use of an in-office pharmacy. So once again, a licensed pharmacy. The statement says it is useful to describe the value in-office dispensing brings to physicians, patients, payers, and manufacturers in two ways: having the pharmacy closer to the patient and having the pharmacy closer to the physician. Throughout the statement, it notes the use of in-office pharmacists to coordinate care, manage patients through adverse events, prescribe lower dosages in anticipation of adverse events, limit prescription quantities to limit waste, and pharmacists are adept at helping patients find financial resources. Why a 90-day supply? Dispensing a 90-day supply of therapy places patients at a higher risk of medication errors and increases risks of unnecessary medication wastes. The oral medications used for treating hematology, I'll just say oncology or anti-cancer oncology conditions are frequently subject to changes based on patient response. These therapies often undergo dose changes, holds, and discontinuations based on changes in patient condition. Often providers write for one cycle of therapy at a time without providing any refills for this very reason. Dispensing of a 90-day supplies of a specialty medication will inevitably cause confusion for patients when they experience any changes to their therapy regimen. Why are they looking to expand the authority to dispense medications to those that can administer medications? This bill creates a mechanism whereby a health professional legally authorized to administer medications may dispense a non-controlled anti-cancer medication to a patient. This list of healthcare professionals is very broad and includes nurses, LPNs, and medical assistants. We would advocate for those that are the most adept at dispensing medications be the ones to dispense the medications, i.e. the provider and the pharmacist. In closing, we ask you to oppose the bill in its current form. However, we are willing to work with the sponsor of the bill and the stakeholders to achieve the best outcome for our patients. Thank you.
Any questions? Senator Prentice.
Thank you, Senator Birdsall. And good morning. Thank you for joining us, and thank you for taking my question. I just want to go back to the why a 90-day supply. There was a prescription that I've had that I used to get in 90 days, and then they changed it. So every 30 days, I have to go back into the system, press the button, or make a phone call, and then sometimes insurance needs to approve it, sometimes they don't. Where before it was 90 days, and I had regular check-ins with my physician, so if they needed to make a change, they'd say, stop that dose, I'm going to move you to this medication. So I'm trying to, is it your position that giving a 90-day supply, even with physician interaction or provider interaction along the way, still presents a patient safety issue? And I think the word you used was confusion.
Yeah, because as I stated before, these oncology medications often do undergo changes. And so what we're looking for is once again, we're willing to come to the table to talk about what a reasonable day supply might be.
Okay.
And so 90 days is probably a little bit excessive for clinic dispensed medication. So right now, when you look at hospital pharmacies or emergency departments, we're limited in the number of days supply we can dispense because we're not dispensing pharmacies. But what we're looking for is potentially recommending that New Hampshire Oncology and Hematology look at applying for a license to be a dispensing pharmacy to ensure that they are meeting the safety requirements for the patients.
Okay.
That makes sense?
It does. Thank you.
Thank you. I'm just thinking of, thank you for the question, senators, because it kind of triggered one for me. I'm just thinking of the patients, that may have limited funds and have to keep going back and going back. And if the oncologist says, hey, look, you need this.
My understanding for the reasoning of the bill originally was to ensure that the patients received a supply until the dispensing pharmacy was able to meet the patient's needs. So that's where we say like a 90-day supply dispensed from a hemonc clinic may not make sense.
And one quick follow-up, if I may, Madam Chair. I know that 39 other states are doing this. Massachusetts, Vermont, Maine.
So once again, I would lead you to that first paragraph where I talked about how these clinics are doing it is including making it a clinic pharmacy where the pharmacist has that ability to be closer to the patient as the pharmacy to ensure that the medications are labeled, dispensed, and the patient is counseled appropriately. So that's how these other states are doing it, is based upon the Community Oncology Alliance's recommendations.
Thank you.
I do have a question related to Senator Prentice's. So you're saying that some of the medications over the 90 days might be tweaked and may change. However, wouldn't it be the physician I would believe that the physician would notify the patient and confer with the patient, and if it needed to be medication needed to be tweaked, they would do a consult with them, whether it's telemedicine or whether it's in person.
They would. But I think once again, going back to the original intent of I understood the bill was really how do you bridge the patient until they can get the medication from a specialty pharmacy. So that's just going back to what I understood as the original intent of the bill.
Thank you. Any other questions from the committee? Seeing none, thank you. Heidi?
Good morning, Madam Chair and members of the committee. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell, and I'm here today on behalf of AHIP, America's Health Insurance Plans. I apologize for my voice. It's coming back from a cold. So AHIP is opposed to SB 458 as introduced, but I will say that we have had a number of discussions and email correspondence with the bill's advocates, and we are certainly willing to continue those discussions and work on an amendment if that makes sense. We have two areas of concern or interest with the bill. One is the 90-day supply, and you've heard others talk about that as well. We had the same reaction, I think, a concern that it could be too long for what's being contemplated. 90-day supplies of prescription drugs are typically meant for treating chronic diseases where the patient's condition is stable, they've had experience being on the drug, it's clear that the drug is working for them, and they're not likely to have a change in treatment. So a 90-day supply would make sense in those scenarios or from a care and cost perspective. But a 90-day supply is not what you would typically think of as necessary to meet the immediate medical needs of the patient, when that's the phrase that's in the current law, meeting the immediate medical needs of the patient. And it's also not, at least from the folks that at AHIP that have weighed in, not what you would typically think of when treating cancer patients. And as you've heard, when treatments plans can be subject to change depending on the patient's condition. You heard that the drugs are often considered to be specialty drugs, and due to their cost and due to the potential changes in the patient's condition, prescribing a 90-day supply could lead to waste of the drug and waste of money, both the patient's money as well as just waste in general in the system. Our other set of questions kind of falls into the category of whether or not New Hampshire Oncology Hematology intends to have in-house pharmacies that are in network. So our understanding is that oral anti-cancer drugs would be self-administered by the patient at home. So we're not talking about physician-administered drugs in a healthcare facility. And so typically providers can't buy and bill for outpatient drugs in the same way that they can for physician-administered drugs. The self-administered drugs need to be dispensed either by an outpatient pharmacy that's in network or through a provider's facility-based pharmacy that's in network. And of course, as I mentioned, there's the specialty drugs, and many carriers require that they be filled through an in-network specialty pharmacy. And the supply would typically be limited to a maximum of either like 28 or 30 days or less, depending on the patient's circumstances. So I think, from the carrier's perspective, we're just trying to figure out how this proposal would be operationalized. The advocates have answered some of our questions. For example, they've indicated that they intend to have a facility-based pharmacy and they would negotiate with the carriers to be in network. So like I said, we're happy to be part of any of the discussions that are moving forward, working on any amendments. And I'd be happy to try to answer any questions.
Any questions from the committee? Seeing none.
Thank you.
Peter Bragdon.
Thank you, Madam Chair, members of the committee. For the record, Peter Bragdon, representing Harvard Pilgrim Healthcare, the state's only not-for-profit health insurance carrier serving the individual and group markets. Pretty much echo what some of the prior speakers have said, so I'll make it quick. The bill does not contain an insurance mandate, so I want to make that clear. We're not concerned that this is some kind of mandate. I think our concern is more long-term, that if this comes into place, there may be at some point a request to make it a mandate that we have to cover this. If this was done via a pharmacy, a facility-based pharmacy that was in network, all the problems would go away in terms of the dispensing issues that we have. But the current system is structured so that medical benefits are covered through one area and drug benefits covered through the pharmacy area. And now we're trying to mix the two to create a hybrid. And I think how to use the word operationalize, there's a lot of logistical problems in trying to make that all work together. However, if they were to do a facility-based pharmacy, as has been suggested by prior speakers and apparently what's done in other states, then that takes care of a lot of those issues. And the other issue we have is, or concern we have at least, is on the 90-day supply. If it was a maintenance drug, a 90-day supply may make sense, but these are very expensive drugs. So if a 90-day supply is given and then 30 days in, it's changed, there's 60 days. You can't bring the drugs back to the pharmacy and say, hey, give these to somebody else. So these are very expensive, sometimes drugs, and so sometimes 90-day may not be wise. So I think some more work on this would be helpful to clear some of these things up and be supportive of that. Happy to take any questions.
Any questions from the committee?
No.
Seeing none, thank you. We have two more speakers. I'll bring Lindsay up and is,
I'll just go.
okay, Lindsay Nato? Okay, you're up. Oh, you were right.
Good morning, Madam Chair, members of the committee. For the record, my name is Rob Berry. I'm the General Counsel of the Division of Medicaid. Director Lippman was intending to be here. He could not be here. I'm not as great as Director Lippman, so I apologize. You're getting the second string here. But I'll try my best. So essentially, we just wanted to reiterate a lot of what you've already heard here. We do oppose the bill for a lot of the same reasons that you've already heard. My understanding, talking to Medicaid pharmacy, is that we typically do not cover 90-day supplies for drugs of this type. We do for maintenance medications, and it makes sense from that perspective. The concern is from a waste perspective, that I understand that there's with this kind of illness, it leads to medication changes. Some people may not tolerate the medication, which leads to medication that's not been utilized. That's a cost for the state that we pay for medication that isn't used. So those are the concerns. In talking with Medicaid pharmacy, they did indicate that perhaps lowering the supply range would be something that we could get behind. But with that, I'll take any questions.
Any questions from the committee? Thank you. Is there anyone here that would, yes, come on up.
My name is Yoni Resnick. Sorry.
No, you're fine because you're down here, but you just checked off support, but
My apologies.
okay.
First time embarrassment.
Welcome.
Thank you. So I am a pharmacist who works for New England Cancer Specialists. We are a community oncology practice with 4 practice sites in Maine and New Hampshire. I'm here to speak on behalf of the concept of medically integrated dispensing as it pertains to the benefits for the patients who are cared for by community oncology practices. A lot of the talking points that have already been made are very relevant, but I just want to emphasize a couple of safety points. There's been some commentary about safety concerns, but from my perspective on the safety side of things, having a medically integrated dispensing pharmacy that allows a provider and patient care practitioners access to everything that is in the patient's chart, concomitant medications, access to real-time labs, drug allergies. That is information that at the point of care definitively improves patient care because you can make those kinds of decisions and interventions in real time. You would then thereby avoid prescribing errors and catch them right at the start. And even if the concept of having a medically integrated dispensing pharmacy, even if the prescription does not stay within the practice's pharmacy, if it has to go to a specialty pharmacy for insurance reasons, you still have that extra set of eyes from that medically integrated dispensing pharmacy before that prescription gets sent out. So very impactful and a huge benefit for our patients and prospectively for NHOH's patients. Also, with these medications that are highly complex and extraordinarily expensive, the coordination of care is just mind-boggling and impossible for many patients, and to have a service available at a practice where there are experts and specialists who can navigate that complex landscape and help patients get financial assistance and grants for these medications has also been hugely beneficial for our patients. Something that wouldn't be as high quality of a service that we offered if we didn't have our own medically integrated dispensing pharmacy. So just here to serve as a reference for the concepts of what integrated medically dispensary can provide for the patient population as a whole.
Thank you. Senator Rayburn.
Thank you, and I appreciate you coming up for the very first time because it can be nerve-wracking, even for us senators. But my question is, how does this differ than, this type of legislation differ from the other 39 states? Is it that significant?
I don't see it being significantly different. The ability for, at least in the state of Maine, for physicians to dispense, it's, to my understanding, very similar wording in the pharmacy regulations. I do not know off the top of my head if there's a limit or a number placed on the day's supply, and I actually don't disagree with a lot of the commentary that has been made about the day's supply. I mean, certainly we don't write for 90 days for very many prescriptions. But in terms of the wording, I think the day supply might be a little bit unique, but the concept of allowing physicians to dispense, I think it's pretty standard across the board.
Thank you, Madam Chair. And we are talking about cancer patients here, right? And so in hematology, and I mean, it's not like, it's just a run-of-the-mill illness. It's something that's very specific, and we're looking at making life a little bit easier for them if they so they don't have to keep coming back in. And obviously, the provider, the physician knows what the physician's doing as far as prescribing this stuff. So I'm just trying to ease their burden, having to come in and at more expense. Granted, it's in the name of safety, but I think that's the practitioner has that in mind, doesn't he?
Yeah, I mean, I could wax poetically about how passionately I feel about this concept and what the service that is offered to the patients means for the patient, not just for the management of their disease, but also for the psychosocial and economic aspects and the burdens that those place on the patient and the family. And by easing the burden on those aspects, even setting aside the obvious safety benefits of what an in-office dispensary means, being able to help coordinate care, serve as a point of contact, not just for the patient, but for caregivers and loved ones, is just of utmost impact. And again, I'll reemphasize, like, we don't treat the patients that we dispense our medications to necessarily any different. We serve as a point of contact for a patient who's getting their medication from anywhere, because sometimes insurances mandate that they have to be filled via a send-out specialty pharmacy. That's a separate issue. But to be able to provide that service just means so much to our patients, outside of the obvious safety and economic incentives for what this does to the, reducing healthcare costs and improving safety.
One quick one, Madam Chair, if I may. There was a concern about this becoming, if it passes, my goodness, the mandates. They're afraid of it becoming a mandate. And is it mandated in Maine and in the other states as well, or is this just a tool in the chest so that it's an option?
Mandate that we fill?
Yeah.
Absolutely not. It's by no means a requirement. If a patient lives far away and it's preferable, and they're not coming into the clinic at the frequency with which they would be dispensed their medications, which is to say usually, monthly. We don't force them by any means to fill with our pharmacy. We offer it as a service, and almost always the patients view that service as preferable to the alternative. But if a patient for some reason wants or needs to have their prescription filled via specialty pharmacy, we of course not only allow that, but we coordinate that, which is another huge a benefit. We have people in our office who know the landscape and can help the patients and their families navigate the landscape. It's so important, but there's by no means a mandate for any patient to fill with us, and I would not expect that to be any different in the state of New Hampshire.
Well done. Thank you.
Thank you.
Thank you very much.
I do have one question. So you've heard throughout, there is a concern about giving 90 days prescription, and then maybe the medication has to change after 30 days or 45 days. What's your experience been on what happens to that leftover medication? Has it happened?
In our experience, and as I mentioned, we dispense 90 days exceedingly rarely. When a medication comes back after toxicity, dose change, whatever, the medication is disposed of. Now, yeah, and with the obvious sequelae of that meaning healthcare dollars being wasted. So I like I said, I understand that that sentiment for the 90 days. What I also can say is that on the specialty pharmacy side, when these prescriptions are sent out to specialty pharmacies, we all of the time in our dispensing pharmacy take back bottles, full bottles, 30 days, multiple months refills, 60 days, 90 days, where patients just continually are sent medications even after the dose is changed or been discontinued, and the specialty pharmacy just continues to send them prescriptions. We have, every once in a while we'll empty out this bin that's full of medications that's been returned to us from patients who get their prescription and are no longer on the drug. So just to talk about the waste that exists outside of what we do.
That's interesting. Thank you. All right.
Yeah, you're welcome.
Just before you close the hearing, for members of the committee, there is a letter that you received by email and in your packet. I'm not going to read it into the record. I just wanted to point it out. It is from the Honorable Virginia Irwin. We call her Biddy Irwin. She served here for a number of years, and Biddy is suffering. She's liver cancer, and it is spread into her spine, and she has concerns about her ability to get the supply that she needs, the number of people that she has to go through, and speaks to this issue quite eloquently. So I just wanted to raise this to everyone's attention. No, it's okay. Thanks. I love Biddy.
You be my neighbor.
With that, I will open the hearing on Senate Bill 555 and welcome the prime sponsor, Senator Abard.
Welcome, Madam. Well, thank you for welcoming me. For the record, I'm Senator Kevin Abard, District 12, and I'm bringing in this bill, SB 555. Committee members, thank you for letting me bring this. And, before I go into my written speech, if you will, I'm in a lot of homes in New Hampshire. And I was just recently in a home where the gentleman was in a wheelchair. His ankles were this thick. And he's on a fixed income. And we get into a conversation. And he says, there are a lot of different things that are bothering me. My property taxes, my food. And then he wheels over to a table and he shows me 2 prescriptions. $1,200 a month just to stay alive. He's on a fixed income. And we get into this conversation and then, by the way, I am a senator, and he says, oh, well, what are you going to do about it? Well, I happen to have a bill, hopefully to give you some relief. But New Hampshire is an aging state. We're one of the most aging states, and there are a lot of individuals that are on prescriptions that could benefit from a bill like this. So I bring to you SB 555. And for the record, again, I'm Senator Kevin Nabard because I wrote it in my speech from District 12, and I'm here today to introduce SB 555, which strengthens the annual reporting requirements regarding the pharmaceutical rebates, and it requires at least 50% of the rebates to be shared with the consumer. And I'd like to start providing a brief history of the issue, seeing that this legislature has recognized the importance of this in the past. In 2020, we enacted RSA 415A7, which requires rebates to be shared in one or both of the following ways: by providing directly to the covered person at the point of sale to reduce the out-of-pocket costs, retained by the insurer to reduce premiums. The statute also requires the insurers to file an annual report with insurance department to verify the compliance. An initial report from the insurance department shows that the insurers are complying with the verification provision by simply filing an attestation. No details or proof of compliance is part of the attestation, which is not what the legislator intended when it was acted into law. And additionally, this statute sunsets in July this year, July 1st, 2024. Senate Bill 555 makes minor modifications to the current law, which comes to us after discussion with the insurance department and the governor's office. This bill provides the insurance department with the tools appropriately verified that the rebates held by the insurers are being used to reduce premiums, and yet it is drafted to ensure that no proprietary information is made public in doing so. Additionally, this legislation requires that at least 50% of the rebates that the insurance companies or the PBMs negotiates with the drug manufacturers to lower the actual price shall be shared with the patients. Yay! That's a good thing. At the pharmacy countertop to help the consumer with the out-of-pocket expense. Why should consumers have to use the list price when in many cases that is not the actual price being paid by the insurance company? I would like to highlight that this legislation only requires 50%, which in my belief is already a very significant compromise. Other states have adopted 100% of the rebates shared at the counter. And other states are considering similar legislation, including Vermont, Maine, and Massachusetts. However, this proposal strikes a balance of controlling premiums and helping patients where they need it mostly, and at the pharmacy when they face the out-of-pocket deductibles and the copays imposed by the insurers. New Hampshire consumers are paying more out of their pocket because the actual drug price is not being used when the actual calculation takes place. And I want to provide you with an example of how this works and why it is so important for our constituents. Take Frances, for example. That's kind of cool, huh? It's just whatever. She has diabetes and chronic respiratory disease. She's enrolled in a high deductible health plan with a copay for medicine once her deductible is reached. Let's assume she takes out the medication with the list price of $200, but for which her health plan receives a rebate of $100. Without this bill, during the deductible phase, Frances will have to pay $200 for her medicine, even though her health plan only pays for $100. If this legislation passes, at least 50% of the rebate received by Frances' health plan would have to be passed on to her when she buys a prescription, which would save her $50. And if you're on a fixed income, $50 means a lot. As a result, instead of paying $200 or more for her medicine, she would pay $150. With the lower out-of-pocket cost, Frances may be more likely to take her medicine as prescribed by her doctor, potentially resulting in better health outcomes and potentially avoiding emergency room visits, hospital stays, and cloister services. You will likely hear that passing this bill will drastically increase premiums. And I'd like to point out that West Virginia, whose laws requires the PBMs to share 100% of their savings with the negotiation of medicines directly with their patients, the insurance filing rates indicate that premiums increased in West Virginia are within line of the national premium increases and did not dramatically increase. Again, the proposal before you allows the insurers and PBMs to retain 50% of the savings for the premium reduction. Additionally, at the request of the insurance department, which I believe they're here, and thank you very much, I have drafted an amendment to further strengthen the reporting requirements, and they'll kind of go over the amendment if that's okay. We'll go through the details. The New Hampshire legislature has the opportunity to truly help branded staters afford their medication. And we recognize this 4 years, we recognized it 4 years ago, and will help extend and improve the drug affordability for thousands of our constituents. And I really ask you to support this bill. People are struggling, and this is a way to address that. I know they're struggling because of the high cost of many different things. So with that, I'll take any questions if you have any, but if you want the professionals to talk on it,
Senator
I'm
Whitman.
willing to, yes.
Thank you, Madam Chair, and thanks for taking my question. I also hear the same thing from my constituents. They're struggling to pay all their bills, and this is another huge part of some people's budgets. I know carriers are fairly profitable in New Hampshire. Why not 100% go back? Why 50?
Well, we're hearing the claim that there might be premium increases, and so, that makes my little squirrels go in my head. Because what we're saying is that the seniors and the people that are on fixed incomes are subsidizing premiums. That doesn't work for me. We set this up so that it would be a little bit more accountable, and hopefully they could take advantage of lower costs. But it doesn't seem to be working that way. And I've yet to see any premiums go down. Does that answer your question?
Thank you.
Yeah.
So I guess you could say that this would be a first step to see if the premiums do increase and how much.
Yeah. And significantly, whereas some claim it is, but in West Virginia, like I said, they're basically keeping at the national rate. So there's nothing that is askew. I believe Maine actually adopted 100% as well. But again, with the Bradley special, this is a compromise. Thank you, Senator Bradley.
Avard special.
Happy Valentine's
Happy
Day,
Valentine's
Avard.
Day.
Any other questions from the committee? Seeing none, thank you.
Thank you, committee members.
Commissioner and company.
Do a good job.
Good morning, Senators, members of the committee. Happy Valentine's Day. DJ Betancourt, Commissioner of the New Hampshire Insurance Department, joined by my colleague, Dr. Jason Azes, our Director of Health Economics. More informally, I call him my PBM guru. First, I'll start by saying that with the exception of Senate Bill 173, our No Surprises Act project, I don't think a piece of legislation this session has taken up more focus and attention of our department than Senate Bill 555. I will say that I am not complaining. Working on important pieces of legislation is an important part of what we do, and by and large, we enjoy it. But the consequence of that will be that this will be some of the lengthier testimony I've given before the legislature. As it pertains to where rebates should be applied, whether that be at point of sale or worked into premiums, I have been very consistent, maddeningly consistent, in saying that that is a policy decision for you all to decide. You are going to hear a lot of competing testimony today, and you will have to determine which direction you think is best. The only comment that I will make on that point, because you are going to hear it referenced this morning, is to acknowledge that as part of our annual hearing, we did do an actuarial analysis on rebates. And our actuarial firm, Oliver Wyman, reported the actuarial value of prescription drug rebates in 2022, which is the last year for which we have complete data, was $38 per member per month, which represented an 11.7% increase from 2021. $34 expressed as a per capita annual cost equates to $456 per person in 2022, up from $408 in 2021. Across commercially insured markets, the total value of rebates was approximately $90 million in 2022. So along those lines of logic, if this legislation were to pass with the 50% rebate at point of sale, approximately $45 million could potentially be absorbed into premiums. Now, is that likely to happen? To that, I have a thoroughly unsatisfying answer for you. I don't know. That is my honest answer. I don't know how that 50% rebate remit requirement at point of sale would play itself out. There are practical perspectives to consider. For example, a person has a $15 copay for a drug that costs $500. If the rebate on that specific prescription is $400, the copay is still $15. Even if the $15 copay is waived to reduce the out-of-pocket cost, only $15 would be credited at point of sale despite the $400 rebate. So that's a practical concern. I don't know how that plays out. Beyond that, I don't know how the market will implement the systems to guarantee the 50% requirement. Some may try to work around it, while others may eliminate rebates entirely. So perspectives and opinions on that point are varying, as you will hear, but I just cannot tell you with certainty how that will play out. And as I have said, you have the choice as to how you wish to proceed, and that decision is yours, and we will obviously execute whatever decision you decide. But I did want to reference that because it is essentially department work product, and so I wanted to address that at the outset because you're going to hear that cited today. With all of that said, I am here to advocate for the transparency and accountability provisions in the amendment before you. When you established the current arrangement a few years ago, we were tasked with collecting reports from carriers on how things were unfolding as it pertained to rebates and premiums. Unfortunately, we discovered, and I think those who got those reports and read them, I think, would agree, that the law did not provide us with the authority or the tools necessary to get data that was of value. And frankly, my team, Dr. Az's, was a bit upset that we lacked that ability because we pride ourselves on providing high-quality reports and information to the legislature whenever you give us that responsibility. So this amendment would address that issue by being specific and being clear as to the data, information, methodologies that the carriers and PBMs need to provide to the department. And it strengthens our ability to provide oversight to this important segment of our healthcare delivery system. This will then allow us to better understand and report back to you on how things are playing out. We would obviously make that data available to the public and to all of you as well. Where appropriate, of course, we will probably have to aggregate some of this data so that we do not run afoul of disclosing any proprietary information. But we'll be able to, as I said, provide you with a much more detailed assessment as to how things are playing out. So we do support those transparency and accountability provisions, as does the governor. Finally, I would just point out with regards to sections D and E, those sections are related to anti-steering initiatives that some other states have created to prohibit. Our position is that laws prohibiting steering by PBMs to their mail order pharmacies inhibit the economic benefits of vertical integration. So we believe that a legislative approach that balances the importance of transparency with financial incentives to promote efficiencies in prescription drug delivery, we think that can produce the best result for consumers. So that is where the department stands, and as always, we are happy to take your questions.
Any questions from the committee? Senator Bradley?
Thank you very much. First of all, you wrote this bill at the request of the governor, is that correct?
So the governor made his position on what he would like to see known to the department. He asked us if we would provide him with language that would accomplish what he wanted. And as we do for the legislature and a lot of others, we were happy to offer that language.
Thank you. Yeah, I've got a couple. There are other states that do this. What is the sense of the department of the results in other states?
Sure. I'll have Dr. Razis address that.
Thank you. So as Senator Avard mentioned, you're looking at West Virginia with their share the savings law. They said they
Can you use
pass
the
on,
microphone a little more?
they pass on 100% of the rebates, and in the year following that, they did not see any upward pressure on premiums. There's some latency to that measure. It takes several years for that economic effect to exert itself in upward pressure. So, you know, different laws in different states vary. New Hampshire, we try to value the importance of free market forces and economic incentives to help glean robust rebates and discounts for the benefit of consumers in getting their drugs with the, you know, the directness of consumer benefit. And so there's two ways, and the department took no position on which way was better, rebates at the point of sale versus those rebates applied to future years' premiums. We merely want to see a better accountability process and transparency with that. And so that was the position that we took, to try to preserve financial incentive for vertical integration to negotiate better discounts on behalf of citizens getting these important drugs, and some of the economic benefits that might come in future years, knowing that prescription drug costs are progressively increasing each and every year, especially for the more expensive specialty drugs.
Thank you, Madam Chair. So my understanding is, having spoken to everybody on every side of this issue, the carriers and the PBMs who are opposing this bill are claiming that they pass the effect of the rebates on to all consumers through lower overall health insurance rates on a per member per month basis. And I'm sure we're going to hear that testimony this morning, okay? Then they come to your department and they attest to having done that. Is that correct? But you don't really know, because you, generally speaking, don't do the thorough dive like the Public Utilities Commission would do with a rate case and examine whether that self-attestation is actually correct. Is that the case? Have I got that right?
Yeah, more specifically, the attestations are not granular enough to reconcile the value of those rebates, so we could track that, yeah.
And so, I guess since, Commissioner, you were the one that proposed the 50% compromise because of the dynamic here of lower overall rates for everybody versus partial of 50% rebate to all customers, I mean, to the specific customer. Isn't that a reasonable compromise that, you know, protects not only our desire for lower overall drug costs reflected in policy and premium costs, but at the same time, for the people that are really burdened the most with the cost of drugs, they're getting something. 50% is something, and it's better than just this amorphous self-attestation claim that rates are lower overall. Isn't that a good compromise?
Well, first, let me say that the 50% decision was not mine. This is not my department's bill. This was at the request of the governor. As I said, the governor shared with us what he wanted to see. But you came up with a 50% compromise. I remember that in the conversations we had over the summer. Well, I think the question the governor said was, or asked was, and others was, I think to Senator Whitley's question, why not go 100%? We said the reason you don't want to go 100% is you start to disincentivize the PBMs from being motivated to negotiate better prices for consumers. So he was the one who said, well, then 50% probably makes some sense.
I
So
guess
that's what he
then,
wrote.
sorry to be running at the mouth here, but isn't that a good compromise? I want to know your opinion and the opinion of the department.
Senator Bradley, as I said before, I don't know, because I don't know how this is going to play out.
All right.
Any other questions from the committee? I actually do have one. Other than West Virginia, are there any other states that have passed similar legislation?
Right now, there's current proposals in Massachusetts, New York, and Maryland that aim to share the savings. And I think in all three of those examples, they aim to glean 100% of the rebates to return to point of sale.
Okay, so they haven't passed it yet. It's in the process, correct? Okay, thank you.
Thank you.
Henry?
Good morning. Thank you. For the record, Henry Lippman, State's Medicaid Director. I want to confine my comments to the Medicaid program, which works very different than the commercial market. One important thing I would like to lift up is that the rebates are an essential part of financing the Medicaid program. Medicaid beneficiaries have very nominal copays. The way our rebate system works is much different than the commercial market. There are different stages of rebates. I guess to kind of make it simple, I would like to see you amend the bill to carve out Medicaid from this, and I can leave my testimony at that. If you have any questions, I just think it's not going to work the same way. In fact, we could have a perverse incentive paying people that aren't paying for any premium and a very nominal copay.
Thank you. Thank you, Madam Chair. But other than that, as far as the reporting, you're okay with that?
We don't have any problem with reporting information.
Yeah, thank you.
Thank you, Madam Chair. Thank you, Director Littman. Do you know if in West Virginia, there's a carve out for Medicaid?
I'm not aware of how West Virginia finances that. I mean, I can reach out to the Medicaid director in West Virginia. I know her pretty well. But I think the unique aspect of, particularly with the Grant Advantage program, is we don't use any general funds for funding it. So the rebates that come in on the Granted Advantage people would be lost in this, and that would probably upend the financing of the Granted Advantage program.
Follow-up? Yeah, if you could, and bring that information back, that would be
Sure.
really helpful. And a related question is it unique in New Hampshire that we use so much of these rebates to fund our program?
I honestly don't know the answer to that. I think generally New Hampshire tries to take advantage of the opportunities to fund things other than in general funds. And I'm not sure I can get you a quick answer on that.
Okay, thank you.
Any other questions? Seeing none, thank you.
Thank you.
Peter? You did say that you're speaking.
I did. I didn't know if there were other Peters in the audience. Thank you, Madam Chair, members of the committee. Once again, Peter Bragdon, representing Harvard Pilgrim Healthcare, the state's only not-for-profit health insurance carrier serving the individual and small group, large group markets. Here with some concerns about the bill. Actually, I guess oppose the bill, but I will start off by saying we're actually in favor of the increased reporting and transparency piece of the bill. The piece we're concerned about, has been mentioned, is the issue of the returning of rebates. Right now, we use 100% of the rebates to reduce premiums. And let's see, last year, the inclusion of pharmacy rebates reduced member premiums by about 6.5% to 7.5%. which I think comes out to probably $60 per month. And so those are plowed directly back into the premiums. So obviously, to the extent that's reduced, that increases premiums. I know from, as policy decision makers, having been in these seats myself, it's always a balancing act between various things on one side, various pieces on the other side. The money's going to be made up somewhere. And our concern is the rate. And I can't speak to maybe what happened in West Virginia. I don't know the situation there. As the department testified, there's some latency as well. Maybe there's only one big carrier in West Virginia. Maybe that one big carrier owns their own PBM. So a insurance company that owns a PBM has a lot more flexibility. They can give the money back to the point of sale because the PBM is getting some rebates that then go back to the insurance company as an administrative fee. So what this bill does, by taking away any flexibility, in New Hampshire right now, some insurance companies can decide to do 100% point of sale rebates. Some can decide to put 100% back into premiums and let the market decide which one is best. But the smaller companies are at a disadvantage if they don't own their own PBM because there's less flexibility there. So our concern is that despite those who say there's no proof of it, and I think when Heidi speaks, she'll reference a slide that the department indicated as well that shows in 2022 how much money from rebates went back into premiums, something to the effect of $38 per member per month or something like that. So a significant impact to every single policy payer. And I do understand that there are people, when they're purchasing drugs, there's an effect there. So it's like the balloon. We always talked about the balloon. You squeeze one and something else happens. So poor people who have trouble affording their insurance premiums, to see them go up $30, $40, $50 per month, probably will either stop getting insurance, go to a higher deductible plan, skip some of the treatments. So our concern is we want, as a nonprofit health insurance company, we want to see as many people as possible have health insurance. And we are concerned that taking away our ability to use all of the rebates to reduce premiums makes that more difficult. But we do understand the balancing test. And I think that was the big piece I was going to mention. Like I said, we do support the increased reporting and disclosure. I would say if you plan to, I don't have the bill, I do have the bill in front of me. If you do plan to pass something like this, I believe it would be better if it took effect January 1st of 2025. We already have contracts in place with our members as well as providers. So January 1st, 2025 for any changes that affect how our business operates would be very helpful because we're pretty much locked in. I think that's enough. I'll take any questions.
Any questions from the committee? Seeing none?
Ooh.
Thank you, Peter.
Get out while the getting's good. Thank you.
Heidi? Sorry.
Thank you. Thank you. Good morning, Madam Chair, members of the committee. I'm Curtis Barry, again here on this bill representing the Pharmaceutical Care Management Association, PCMA, which is the National Trade Association for the PBM industry. First of all, a little news update. The state of Maine, the committee has voted to not pass the bill in the state of Maine. Other states are still in the process. And there are 4 other states besides West Virginia that I believe have passed this. Those 4 just in 2023, so, the jury's out. Also, my understanding in West Virginia, the statute that they were operating under prior to was not like ours, that requires one or the other, where it's passed through, most of the carriers do, pass through to benefit to lower premiums. Their statute treated it differently, so it may be a little harder to determine. I want to start by saying, first of all, this bill, I'll back up. PCMA is opposed to specifically in the amendment lines 8 and 11. In the bill, it's lines 24 through 29, which is the point of sale rebate. The rest of it is fine. I know AHIP has worked with the department on the reporting requirement so obviously that works for us as well. Keep in mind, this bill will do nothing to lower the cost of prescription drugs. It only changes who pays what. At the end of the day, pharma still charges what they charge. Our view is this bill is allowing the state to micromanage decisions that should be a plan design decision between insurers and the people that they sell the premiums to. It's important to understand, first of all, how a rebate works. What is a rebate? Rebates only apply to less than 3% of the prescriptions dispensed. Roughly 90% of the dispensing, or the prescriptions dispensed are generics. Rebates generally don't apply to generics. Rebates do not apply when there's a name brand drug that has no competition. There's no leverage to negotiate the rebate or the discount on that drug. So less than 3%. So the sponsor's example, we don't know if that's a drug that's rebated or not. If it's standalone and has no competition, the price is the price. The rebates are negotiated by PBMs on behalf of their clients. It will include commercial insurers, as the Harvard Pilgrim example. It will include state governments, local governments, county governments. It will include self-funded plans. The reason they exist and the reason why they're able to negotiate these discounts from the manufacturers is volume. A PBM negotiating on behalf of tens of millions of lives has more leverage than, for example, the state of New Hampshire health plan, which negotiates on behalf of tens of thousands of lives. And one of the mechanical problems with what you're asking is that rebates, because they're volume driven, are calculated on a quarterly basis retrospectively. The pharmaceutical manufacturer will offer the rebate based upon volume, and you don't know that volume at the point of sale. So that gets into a little bit of mechanical difficulty. The rebates as we know them today are the result of both federal statutory changes and litigation in the 90s, roughly speaking, the 90s, when I understand that independent pharmacies or pharmacies generally brought a antitrust action against manufacturers. That shifted the nature of rebates to the volume discounts, and that's how we have them today. And they've been used demonstrably to lower the premiums, to lower the cost of the prescription drug benefit, to make it affordable for employers to provide this. So I want to point out 3 impacts that these sections that I am speaking to will have. First of all, as I testified on previous legislation, this will drive action or prescriptions to higher cost drugs. It disincentivizes lower cost drugs. A side note I'll make, given some of the examples that you've heard about an individual and anecdotally at the point of sale, the way this is written, the way I read it, requiring a minimum of 50% of the rebate to pass through. Theoretically, is it possible, I'll ask you to ask yourself the question, theoretically, is it possible for the patient to leave the prescription counter with cash in their pocket? If they're getting 50% of the rebate and their out-of-pocket costs through copay or whatever is less than the rebate, they do cash. I don't know. That's the way I read it. More importantly to PCMA and its member companies, which in this state primarily include Anthem, CVS Health, Express Scripts, which is part of Cigna. This allows pharma a look into what right now is proprietary confidential information that's been negotiated between an individual PBM and an individual manufacturer for an individual drug. The Federal Trade Commission has found, and I'll quote, if manufacturers learn the exact amount of the rebates offered by competitors, the required disclosures may lead to higher prices for PBM services and pharmaceuticals. When you disclose this information, you're removing the competition. Lastly, the third impact is the premium rates. You've already heard enough about that. I'll just add a few additional pieces. We know the insurance department's report That's demonstrable. The federal government in 2019, the Congressional Budget Office estimated that, says while some Medicare beneficiaries would have lower drug costs, again, some, less than 3% of prescriptions dispensed. While some Medicare beneficiaries would have lower drug costs, overall cost to the Medicare program will increase by $170 billion over 10 years, causing premiums to increase for all beneficiaries. The CBO also estimated that Medicaid costs would increase by $7 billion over the same period. I'll get back to Medicaid in a second. We did pick up that there's an updated fiscal note dated February 6th. It not only mentions Medicaid, it mentions the state employees' health plan. Now, I can't say whether this bill as written applies to the state employees' health plan, but there's an impact there as well. And I will conclude with 2 points. If you're not willing to impose this additional cost on Medicaid, on the state of New Hampshire, on the state employees' health benefit plan, the state of New Hampshire, why are you willing to impose the additional cost on the employers, on small businesses of the state? That's the first point. The second point is, how do you help the folks that this is intended to help? Farmers should lower their prices. We've seen the headlines. This is what we've seen over the last few years on a regular basis. We don't control the list price. PBMs don't control the list price of the drugs. Only pharma does. I'm going to leave you with 2 handouts. One is a PCMA document that reiterates some of the points that I've made. This one is a list, a scorecard, if you will, of patent activity on some of the more common drugs. For example, some of the ones that I recognize from the $3 to $9 billion that pharma spends on direct-to-consumer advertising. Trulicity, 57 patents, 49 of them after FDA approval. Keytruda, it is rebated, as was Trulicity. Keytruda has 180 patents, 111 patents after FDA approval. If you want to know where the high cost of drugs is coming from, take a look at this sheet. I'm happy to answer questions to the best of my ability. Sam Hollemeyer from PCMA is here to hopefully answer questions that I might not be able to. And thank you for the opportunity.
Any questions from the committee? Seeing none, thank you. Heidi?
Good morning, Madam Chair, members of the committee. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell, and I'm here today on behalf of AHIP, America's Health Insurance Plans, to testify in SB 555. We are opposed to SB 555 as introduced. We are opposed to the proposed mandate in Section 2 of the bill that would require at least 50% of drug manufacturers' rebates to be used to lower the patient's out-of-pocket costs at the point of sale. We are also opposed to the provision in Section 2 that would increase the fines on carriers for each violation, which we take to mean per enrollee. The proposal is to increase those from $2,500, which is standard throughout New Hampshire's health insurance laws, to $10,000, which would be a 4-fold increase. We believe a $10,000 per enrollee fine would be an excessive fine and is unnecessary, is an unnecessary proposed change. The insurance department already has the statutory authority and necessary tools should it need to take enforcement action against a carrier. And that includes the provision that's already currently in RSA 415A7 that says the commissioner can suspend or revoke a carrier's certificate of authority if a carrier violates any provision of the law. I would note that carriers do not object to the enhanced reporting requirements to the insurance department I'm not sure if Senator Avard is the one who brought in that amendment or the proposal came from the department here this morning. But the changes were proposed by the insurance department and reviewed by the carriers, and they are changes that we can live with. We don't have any problem with that. Taking a step back, health insurance carriers are Americans' bargaining power. Negotiating lower costs of care and lower drug prices for plan enrollees. That includes negotiating discounts off the list price of drugs and maximize the impact of those discounts, which are known in the industry as rebates. Maximizing those for all plan enrollees by passing along those savings through lower out-of-pocket costs, reductions in premiums, and other improvements to benefits. It is important to note the pharmaceutical manufacturers only offer rebates on select brand name drugs that have competition. If a brand name drug does not have any competition, manufacturers don't offer any rebates. The reason manufacturers are willing to offer these discounts is so their drugs can get better placement on the carrier's formularies and be prescribed to more patients. So better placement on the formulary means being on a lower tier. Lower tiers have lower patient cost sharing than the higher tiers have. The amount of the rebate for a particular drug is very often tied to the volume of prescriptions sold. The more that is sold, the bigger the rebate is. Rebate amounts are typically determined well after the plan year ends and the pharmacy claims have been settled. Under New Hampshire's current law, carriers must use drug manufacturers' rebates to either lower insurance premiums or lower the patient's out-of-pocket cost at the point of sale or some combination thereof. Most insurers are using the rebates to help lower premiums and lower cost sharing for all enrollees. Point-of-sale rebates won't help patients who take generic drugs, which account for more than 90% of the market. Point-of-sale rebates also won't help patients who take brand name drugs that do not have competition in their therapeutic class, because again, rebates are generally not offered for those drugs. So how do patients who use rebated drugs benefit when carriers use the rebates to lower premiums and improve benefit designed for all enrollees, rather than using the rebates at the point of sale? There are 3 points that I want to make. First, these patients benefit from lower copays or lower coinsurance because the rebated drug is on a lower tier. And because the rebated drug is moved from a higher tier to a lower tier, it can even mean that the rebate bought down the patient's cost sharing from coinsurance to a copayment, which also means savings for the patient. Secondly, when rebates are used to lower premiums, the patient benefits from lower premiums, just like all of the other premium payers in the plan. And third, patients will also see lower cost sharing overall when rebates are applied to premiums due to the actuarial value requirements. AV is based on net expenses after rebates, so cost sharing across all medical and drug benefits is all reduced by rebates. So it's not just premiums that are lower, but total cost sharing is lower as well. So why should rebates be used to help lower premiums and cost sharing for all premium payers instead of funneled toward a select few patients who are using rebated drugs? The reason is that premium payers are the ones who pick up the lion's share of the cost of those patients' brand name drugs once the patients meet their deductible. As you know, insurance is about sharing the risks and the costs of healthcare, and any discounts or savings should be shared as well in calculating essentially net cost. As you know, SB 555, as introduced, would mandate the carrier shift at least 50% of the rebates from reducing premiums and cost sharing for all beneficiaries and shift that over to reducing cost sharing at the point of sale for a limited number of patients who are using rebated drugs. This will increase premiums, plain and simple. When you redirect rebates away from lowering premiums and you redirect that money toward a small group of patients, premiums will go up. It's just how it's going to work. I would like to point out, and it's been referenced in other testimony, the New Hampshire Insurance Department's annual report from December of 2023, which has data for 2022. On slide 49, which is one of the handouts that I've given you today, it shows that in 2022, due to insurance carriers applying rebates to lowering premiums, they lowered the per member per month cost of prescription drugs by $38 from 147 down to 109 per member per month. That is a 26% reduction. It's not insignificant. Also, at the bottom of slide 49, it states the total pharmacy rebate dollars across all commercial fully insured markets, excluding United Healthcare Freedom Plans, was $90 million in 2022. So as Commissioner Betancourt indicated, under SB 555, you would take away at least half of that, namely $45 million from premium reductions for citizens and employers of New Hampshire who are in the commercial fully insured markets, $45 million. Next, I would like to point you to the fiscal note, the new fiscal note that Mr. Barry referenced. And first, the insurance department does indicate in that fiscal note that the bill would result in upward pressure on premiums. Second, the Department of Administrative Services indicates that the state of New Hampshire Employee and Retiree Health Benefit Plan pays the full cost of pharmacy claims less any member copayments. In 2022, they indicate that the state's gross prescription drug expenditures were approximately $125 million. Administrative Services indicates the state currently receives 100% of drug rebate revenue from its PBM to offset its drug costs, much like what carriers are doing for New Hampshire employers and individuals through their insurance plans. DAS indicates that in 2022, the state received approximately $41.1 million in rebates to help offset the state's drug costs. So I pose this question: as the payer for the state's employee and retiree health plan, would the state of New Hampshire want to divert half of $41 million away from lowering its drug costs? Because that is what SB 555 seeks to mandate for New Hampshire's businesses and individuals in the fully insured market. Third, in the fiscal note, the Department of Health and Human Services also indicates that they are concerned about the fiscal impacts of a 50% point of sale rebate mandate in the Medicaid program. They indicate that Section 2 of the bill would result in an increase of at least $30 million in general fund expenditures. I would ask again, as the payer for the state's Medicaid program, would the state of New Hampshire want to see a cost increase of at least $30 million? Because again, this is what SB 555 seeks to mandate for New Hampshire's businesses and individuals in the fully insured market. A little bit more background, when the Trump administration adopted a similar point of sale rebate mandate in the Medicare Part D program, CMS's own actuaries estimated that it would increase premiums by 25%, cost taxpayers between $200 and $400 billion with a B, and lead to a $137 billion windfall for pharmaceutical manufacturers. That is CMS's actuaries saying this. Congress has continually disallowed this federal rebate rule to take effect. Finally, I would like to mention Colorado. The Colorado Division of Insurance engaged Milliman, which is a worldwide provider of actuarial services. They've been used here in New Hampshire as well on a number of occasions. Used Milliman to complete an actuarial study analyzing the effects of point-of-sale rebates on customers in Colorado's individual health insurance market. There are three findings in the Milliman report that I wanted to call to your attention. First, the Milliman study estimated that premiums would increase. Second, the Milliman study cautioned about negative impacts on Colorado's 1332 waiver program. Like New Hampshire, Colorado operates a state-based reinsurance program in the individual market through use of a Section 1332 waiver. The Milliman report found that if rebates are passed through at the point of sale, this could decrease reinsurance payments, which would mean upward pressure on premiums. As you know, New Hampshire has been very proud of the downward pressure that the 1332 waiver has had on the New Hampshire marketplace premiums for Granite Staters. A point-of-sale rebate mandate would likely undermine that success. And third, the Colorado Milliman report found that there could be operational challenges for pharmacies, carriers, and PBMs with implementing point-of-sale rebates. As the report describes, the correct discount at the pharmacy counter would need to be identified for each member. The discount would vary by drug for each carrier and formulary offering, and the discount could change throughout the year as PBMs continue to negotiate rebates in response to market events. They also note that rebates are paid retrospectively, so if health insurance carriers were expected to bear the cash flow risk before the rebate is received, that could be another concern. So all of this is increased operational complexity, and it could increase health insurer administrative cost, which would further increase premiums. So in closing, nothing in SB 555 addresses the root cause of high drug costs for consumers, which is the high list prices set by manufacturers. SB 555, from our perspective, would allow manufacturers to continue to raise their prices year after year, which would increase the cost of this requirement even further. A recent AARP report looked at 217 drugs that were on the market from 2006 to 2020. And for these drugs, the cumulative price increase over this time was nearly 280%, while the increase in general inflation over the same period was only 32%. When considering a bill like SB 555, we would respectfully mention that it's important to consider the people who are not in the room today, New Hampshire's individuals and small business employers who are doing their best to keep up with the rising healthcare costs and rising drug prices. Those are the people who would ultimately pay for this proposal. And with numbers like 20 million or 30 million or $45 million, it appears that New Hampshire citizens' employers would face a pretty high price tag. So I appreciate your time and consideration of this testimony today, and thank you very much.
Thank you, Heidi. Any questions from the committee? Senator Avon.
Thank you. And thank you for your testimony, Heidi. Appreciate it. As far as the reporting, it seems as though that seems to be an issue of transparency. I did a job up north, and happened to be a pharmacy, and I'm sucking up water, cleaning up a flood. And I said, by the way, do you know I'm a senator? And we got on the topic of PBMs. And the first thing he said, the pharmacist, transparency. We need transparency. And it was like he was emphatic. Doesn't this bill help out with transparency?
So thank you for the question, Senator. There are two parts of your bill. Section 1, let me just get to the. So yes, to answer your question, yes, this will improve, transparency and reporting. As I mentioned, from the carrier's perspective, we don't have any issues with the additional reporting requirements that I don't know if it was you, Senator, who brought in an amendment today, or if it was Commissioner Betancourt, but I know there was mention of that. And we did work with the department. We looked at what they were proposing, and that was fine. And then, of course, there's Section 1 in your bill as well that has reporting. So, I think no problem sharing that data with the department, and so that they can be able to say with certainty to anybody who asks that they have verified the data.
Thank you. Follow? Thank you. RSA 415A7 basically is done by July 1st. So there was testimony saying, can we postpone this bill if it should pass till next year? But yet there is a deadline as of July 1st. How do we work that out?
Thank you for that question. I'm glad you pointed that out. So, yes, I think from AHIP's perspective, the law as it has been on the books from the perspective of either using rebates to lower premiums or point of sale rebates or some combination thereof, we are not advocating to sunset the bill. So we don't have any issue with that. We agree that, this could stay on the books and that part would need to be addressed. Our concerns really are with as I mentioned, the two aspects, the mandatory 50% point of sale rebate, that's a concern for us. And then the proposed fourfold increase in the fines is a concern for us as well. As I mentioned, the insurance department already has the tools for enforcement. And, even current law has the $2,500, which we take to mean $2,500 per enrollee for a violation. And it also has been on the books, and I think it's elsewhere in insurance statutes as well, but specific to this particular piece of legislation, it's been on the books that the department could suspend or revoke a carrier's certificate of authority if there were any violations. So, I would say that, I know that people have questioned the attestations that are being filed with the department. I understand that there's an interest in having more data behind that, but I will tell you that the professionals who work for the carriers who are signing those attestations take that seriously. They are not willing to jeopardize the carrier's certificate of authority to be operating, and they're not willing to risk fines either. So I do say with confidence that the carriers, what they have been attesting to is truthful.
Last question.
Last question, okay. Well, I would imagine if they're complying, they don't have to worry about the fines, but based on the testimony, you did, at least I thought I heard you say that there are very few people getting the rebates, basically are subsidizing the rest that aren't. And I know that the theme behind insurance is spreading the risk, but there are a lot of people that are on fixed incomes that may be that small portion that are getting the rebate are subsidizing the rest. And we're looking for relief.
Yeah, I'm not, with all due respect, I'm not sure I agree that those people are subsidizing all the rest. I mean, is the way insurance works, as you know, is that everybody, carriers develop premiums, deductibles, cost sharing. It's a program design, a benefit design that hangs together. Yes, people are asked to meet deductibles, and yes, they are asked to pay co-pays. But the lion's share, that's what insurance is designed to do. The lion's share of costs are being picked up by all of the other premium payers. So, yeah.
Cam, do you know if it's available? Okay.
I thought I had it.
No, we don't have it.
And the final thing I would say, Senator, too, is I don't believe that this piece of legislation would apply to Medicare. So it's important to keep that in mind. Yeah. Thank you.
Thank you, Heidi. Beverly Goodell? We have one last speaker on this bill, and we have 3 more bills to hear, so I will try and keep this moving.
Good morning. Thank you, Chairman. Thank you, Committee. My name is Beverly Goodell. I'm the Executive Director of the Lupus Foundation New England. We serve all people in New England, New Hampshire in particular, and Massachusetts and Rhode Island. Our mission is to support people with lupus, promote awareness, and fund scientific research for lupus. It's a pleasure to address you today. And I also want to thank you for placing the needs of the patients and the residents of New Hampshire above all else. I'd also like to thank you for your dedicated service to your state and your unwavering efforts to lower healthcare expenses for patients. I'm here today in support of Senate Bill 555. The bill will have a direct, meaningful impact on the lupus community we represent, because it will reduce out-of-pocket expenses for those who need it the most, our patients. The legislation improves access and affordability to vital medications, treatments, by requiring insurers to share negotiated rebate savings with patients at the pharmacy counter. Senate Bill 555 mandates that 50% of these savings be passed on to patients and ensures they receive the benefits from negotiated rebates and discounts when filling their prescriptions. As a patient advocate, I strongly believe this is the right decision for patients in New Hampshire and is long overdue. I encourage the committee to strengthen the minimum threshold even more if possible, increasing the percentage of the rebates passed on to insurers by at least 85%. Sharing these savings, in our view, will go beyond helping patients save money on prescriptions. When patients don't have to worry about affording their medication, as you had pointed to, They are less likely to restrict their medication intake or fail to fill the prescription out of fear of being able to afford it. We all know someone, maybe a friend, a neighbor, or even a family member, who had to choose between adhering to their prescription medications or affording groceries. The state will witness improved health outcomes and reduced overall healthcare expenses by making it easier for patients to afford their medications. Today, committee members have the opportunity to guarantee Granite Staters receive these negotiated rebates because patients should not pay more than necessary for their prescription medicines. Thank you so much, and I appreciate your time. Have a good day and happy Valentine's Day.
Thank you, Beverly. Any questions from the committee? Seeing none.
Thank you.
Our last speaker is Rachel Cottle. Welcome.
Good morning.
Morning.
Chair Bartzel, members of the committee. Thank you for the opportunity to testify today. My name is Rachel Cottle Latham, for the record, and I'm Director for State Policy with Pharma. Pharma represents the leading innovative biopharmaceutical manufacturers, and I'm here today on behalf of our members to support Senate Bill 555. This bill would require at least 50% of the rebates negotiated between manufacturers and payers that lower the net cost of medicine to be shared directly with patients at the point of sale. This proposal would lower patients' out-of-pocket costs and provide them with direct, immediate savings where they need it most, which is at the pharmacy counter. This bill can help patients better access, afford, and adhere to their medicines, as the prior testimony attested to, which can improve health outcomes in patient lives and lower costs to the healthcare system overall. But to see how these negotiated discounts are not currently benefiting most patients, we need to look at the growing gap between the undiscounted list price of medicines and a medicine's net price after rebates and discounts. This gap continues to grow as manufacturers negotiate increasingly significant savings in the form of these rebates and discounts with insurers and PBMs. At national scale, these savings totaled $256 billion in 2022. And we heard testimony today from the insurance department of those numbers local to New Hampshire. But patients often are not benefiting. Even though manufacturers offer savings that can reduce the cost of some brand medicines by 50% or more, patients with insurance are still struggling to come up with the out-of-pocket costs they need for their medicines, despite paying premiums each month. In part, this is because the use of deductibles and coinsurance and pharmaceutical cost sharing has increased rapidly over the last decade. Patients with commercial insurance have seen their average out-of-pocket cost sharing for brand medicines increase by over 50% in some therapeutic areas since 2015. And as it stands today, when patients are facing their deductible or pay in coinsurance, the amount they must pay for their medicine is often based on the full list price, even while their insurer and PBM are only paying the discounted amount they negotiated with the manufacturer. This means that the cost to patients is often much higher than the cost to their health plan for the same medicine on the same prescription. This situation is unique to coverage of prescription medicines. Patients receive the benefit of negotiated discounts when sharing in costs for doctor or hospital visits, but they do not always receive the same benefits for prescription drugs. Making sure that patients benefit from these discounts not only has an impact for that patient at the pharmacy counter, but could have a broader impact on the system. Lowering patients' costs at the pharmacy counter can improve health outcomes and generate savings through improved adherence. In 2021, 61% of commercially insured patients did not fill their new prescription when out-of-pocket costs exceeded $250, according to IQVIA. Poor adherence to medicines is associated with worse health outcomes and avoidable healthcare spending. As an example, one study found that greater adherence to diabetes drugs is linked to less hospital use and could save $4.7 billion annually, nationally. This is why Senate Bill 555 is so important. Our industry feels very strongly that manufacturer rebates and discounts should impact patients at the pharmacy counter. And as I start to conclude my comments, I just want to highlight that passing through rebates at the point of sale could save patients significantly on out-of-pocket costs without raising insurance premiums. 3 states, West Virginia, Indiana, and Arkansas, have already enacted rebate pass-through legislation. There was a question raised today about whether the West Virginia law applied to Medicaid? And the answer is no, it does not. In Arkansas, which requires insurers and PBMs to share 100% of negotiated savings directly with patients, a Milliman review of 2024 insurance rate filings indicate that plans are passing through drug rebates to patients at the pharmacy counter, and that there has been no material impact on premium rate increases for Arkansas. At the same time, studies have shown that passing all prescription drug rebates to patients can provide up to $1,000 of savings for patients with high out-of-pocket costs. So in conclusion, Senate Bill 555 balances the goals of controlling premiums and helping patients where they need it most at the pharmacy counter. So for these reasons, we urge the committee to support Senate Bill 555. Thank you for hearing my testimony, and I'm happy to answer questions.
Thank you, Rachel. Any questions from the committee? Seeing none. Thank you.
Thank you.
Is there anyone here that would like to speak on Senate Bill 555 but was not given the opportunity? With that, I will close the hearing. And when Cam is ready. Clear out the room.
Well, welcome, Senator. We're going to hear the prime sponsor for SB 312, and I recognize Senator Bertzel to introduce it.
Thank you, Mr. Chair. Thank you, committee, for hearing Senate Bill 312, which I am the prime sponsor. This is third-party liability in Medicaid. This was a bill that was requested by the Department of Health and Human Services. It provides for health carrier acceptance of liability to third parties under the state Medicare procedures. Francesca Hennessy is here today. She'll provide you for a lot of the information that you need based on the bill. And with that, I will entertain any questions.
Questions from the committee? Seeing none, thank you, Senator. Francesca, would you like to come up?
Thank you. Good morning. My name is Francesca Hennessy. I'm with the Department of Health and Human Services. I seem to have cleared the room, so I don't know whether to be offended or not, but this is an important bill. This is a requirement placed on the states by the federal government by way of a state Medicaid director's letter. They told the states, you must put certain sections in your law. If you don't have them in there right now, you need to amend your law based on a federal law that was passed. In short, it does not allow health insurers to refuse the state's Medicaid claim because there was no prior authorization. The fact that it was part of the state plan covered services is enough to show that it was authorized. So no right of refusal for no prior authorization. Further, these third parties, the health insurers, must respond to a state's claim within 60 days of receiving the state's inquiry. So those are the requirements. Otherwise, the bill was reworked a little bit. We added some provisions that third party cannot refuse the state's claim because of certain formatting things, such as no policyholder information. You cannot refuse us because there's no policyholder information. We often have only the Medicaid member information. You also cannot refuse the state's claim because there's no NPI number. We don't have an NPI number. We are not a provider, if you know what an NPI number is. And that's really it. So thank you very much. Is there, I'll take any questions.
Any questions from the committee? Seeing none, thank you.
Thank you so much.
That was our last speaker. Is there anyone here that would like to speak on 312 that was not given the opportunity? No? Okay. I will close the hearing on Senate Bill 312.
I know. It's not fair. So we will now open up the hearing for SB 400 and entertain the prime sponsor, Senator Bertzel, on SB 400. You are now recognized.
Thank you, Mr. Chair. Thank you, committee, for taking my testimony. For the record, my name is Regina Bertzel, State Senator for District 19, which encompasses the towns of Derry, Hampstead, and Windham. And I am the prime sponsor of Senate Bill 400, which is, this bill reduces or attempts to reduce the cost for medical records and requires them to be provided electronically upon request. There is an amendment, I believe it's a replace all amendment to Senate Bill 400. It's 0679S. There will be people behind me that are a little bit more knowledgeable about the topic. But this bill was brought to our attention because we saw that some of the bills that, not necessarily the patients themselves, but their representatives, let's say their attorneys or their family members, who, when they couldn't get copies of their medical records. I have copies here of some bills that are $1,600, $1,500 for copies of their own medical records. And this bill is an attempt to reduce those costs, especially to those who are representing the patients. So, and this is basically for any third-party vendor with whom a healthcare provider contracts, stores, handles, and issue digital or paper copies of such medical information, medical records. So with that, I'll end my testimony and entertain any questions.
Thank you for your testimony. Questions from the committee? Seeing none. Thank you very much. Kimberly? Welcome.
Thank you, Senator. My name is Kimberly Kirkland. I'm here on behalf of the New Hampshire Association for Justice. I'm a lawyer here in Concord, and I do primarily medical malpractice work, but I also do some personal injury work. And just to follow on Senator Birdsell's comment, this bill is about patients' rights to obtain their own records and then to have their representatives be able to access those records at a reasonable cost. So the scenarios that come up when patients want their own medical records is the patient wants the records for themselves in order to understand what happened. I'm sure we've all been in the situation where you're with a fast-talking doctor or other medical care provider, you can't get down all of what they've said. You want to be able to access your records and understand what's happened to you. And so this bill, Senate Bill 400, impacts both that patient's ability to get their own records and scenarios where a patient has some representative, whether that's a family member or an attorney, who they've designated as the person they want to be able to access and review their medical records, and what the costs would be for that. And the question here is really whether cost becomes a barrier to having the right to access your own medical chart. And I'm sure you're all aware in the late 90s, early 2000s, we saw the advent of electronic medical records. The promise of electronic medical records was it was going to make it easy for providers to share records so that when you went to see your PCP and they referred you to a specialist, it would be easy for the specialist to access those records and vice versa. So all your healthcare providers would be in communication. But as a sort of unexpected consequence of that, there was a period of time where there was some lack of understanding about how to provide electronic medical records. In the past, when a patient or their attorney wanted their records, you would go submit a request to a physical medical records department at a hospital, and they would photocopy medical records for you. This was no longer required because now medical records were stored electronically, or the vast majority of them. There are still a few records that are, or a few providers who don't store their records electronically. But, you know, if I go to Concord Hospital and there's some note taken in the OR by hand by the anesthesiologist, that's going to get scanned in because Concord Hospital isn't going to maintain those records in paper. They now maintain virtually all of their records electronically. And a cottage industry sprung up to help hospitals deal with providing records in response to patient requests or their attorney's requests electronically. And that became a profit center, is what has really happened. And there were real cost barriers to patients obtaining their own medical records, even though we were now in a situation where obtaining the records was pushing a few buttons on a keyboard to download those records onto a disk. We weren't having somebody stand at a copy machine anymore. This was, in fact, far cheaper than providing records had been in the past. But companies grew up like Sharecare and Ciox, who built a business model on charging patients for providing electronic medical records. Under federal law, HIPAA says that a patient has a right to access their medical records, and that the fees for that should be reasonable cost-based fees. There was interpretation from the Federal Department of Health and Human Services about what those reasonable cost-based fees should be. They went through a rulemaking process and came up with reasonable cost-based fee or $6.50, whichever was cheaper. That gave these entities that provide electronic medical records the ability to appear and say, here's what it actually costs us to provide these records electronically. And what ended up happening was they weren't really able to establish that it costs a significant amount to provide those records electronically. And so we got to a situation where records were being provided for that default number, for $6.50 to a patient when a patient made the request. However, there was some dispute about whether under HHS regulations, that same fee would apply if it was a patient's attorney or other representative who was making the request for the records. And the entities that were providing the records, SciOx, ShareCare, those entities took the position that the HHS rules and guidance didn't apply when it was an attorney making the request, only when it was the patient themselves making the request. And you'll hear testimony from another NHAJ member after me about experience they've had with charges when they're requesting records for clients. As an attorney representing a client who's been injured, whether it's a pedestrian hit by a car crossing the street, one of my clients in a medical negligence case, there are two options for obtaining the records. My office uses the option of trying to take advantage of this $6.50, flat fee for obtaining an electronic version of the records. But what that means is that we have a paralegal who spends 70% of her time guiding patients through the process of requesting and collecting their medical records, and then follows up if they don't receive the complete records. So that's a resource we take on so that the patient only incurs $6.50 to obtain their medical records. That requires so much time from one of our personnel because many people are unsophisticated in terms of downloading a record that comes to them by email or clicking on a link from ShareCare to try to download their records. And they don't have the wherewithal to follow up. Maybe they're injured and it's difficult for them to actually even take on the burden of requesting all these records from different providers, collecting them, getting them to their insurance, into their lawyers' hands. So many lawyers opt for the other option, which is you have the client sign an authorization which says, this is my attorney, and I authorize my attorney to obtain my medical records. Please send them directly to my attorney. That's where the third-party entities are charging, in some cases, thousands of dollars. And the way the federal law has been set up, when it's a patient requesting the records, we know that it's $6.50, and that can be done if you can help a patient do that. But if it's not a patient, we now have a federal court decision in a case brought by SciOx, where SciOx said the rulemaking process that was used to come up with the fee for an attorney to request records for a patient was inappropriate. The federal court agreed. So now on the federal level, they're going back through the rulemaking process to set the rules for what happens when an attorney or other representative requests those medical records. So that's a long process. And while it's an unknown on the federal level, the standard result revolves back to the state. So what is state law on what you can charge an attorney for medical records? And so that's what this bill seeks to do, is to set forth, okay, under New Hampshire state law, if we don't have some federal law preempting, what will it cost for an attorney to obtain records for their client? And the amendment as proposed sets an amount of $6.50 if the attorney is getting the records electronically. It doesn't cost SciOx or ShareCare any more to hit 3 buttons on a keyboard to download records onto a CD for a patient than it does for it to be that same CD to be sent to an attorney. The bill also addresses paper records because there are some providers, very few, but there are some small providers, PTs, maybe a VNA, who still keep their records on paper. So there is a mechanism for them to charge copying fees for paper records. But again, there's an effort here in the bill to cap that so that a patient can find out what happened to me, what are my providers saying I needed, what's the care I got. Let me share that with my attorney or other representative for purposes of, recovering after an accident or those kinds of things, and not have that be a barrier to entry in terms of recovery. And it really can be if every provider you've seen over time can charge thousands of dollars in order for you to get your medical records. So that's all I have, but I'd be happy to answer questions.
It's just one question.
Senator Abar.
Thank you, and I appreciate your testimony, and it seems to make a lot of sense. But with the paper fee, is that reasonable? I mean, for, some administrator to go through and copy everything, that is 25 cents.
A page reasonable?
Yeah.
Well, I think that the page charges had been in the old, the existing legislation. I think it was 50 cents, and I don't, to my knowledge, that's not based on any cost of paper or printer ink. And so I think that the real cost of per paper copying for the materials is lower than that 50 cents per page. And it depends on the provider, probably, what the workload or burden is in terms of how those paper records are stored and what it takes to copy them.
Thank you, Senator Bertzel, and thank you for joining us this morning and taking my question. I'm not sure I'm asking this to the right person, but I'm going to start with you. You just at the very end, as you were wrapping up, talked about transferring the electronic information onto, say, a CD, a disc, and sending it, and there being either little to no cost or little to no effort to do that. Correct?
Correct.
Okay. So having previously worked in a hospital that had electronic medical records and also had paper in different departments as well that would have to come in as PDFs, and the emergency medical services side is not always integrated in, which I really think that we should have. When I'm thinking about that all being gathered together, there's to make sure that
Here's what I found.
Well, Syrian was going to answer the question for me. It seems to me that there would be time, that there is time that goes in to make sure that all of that is together, especially so the capture of, say, that written note from I think you referenced the anesthesiologist may still do a paper record. And again, I, can vouch for the fact that not all emergency medical service records are naturally or electronically integrated in. So it seems to me that it might not be like, I think it's less than the photocopying, and there's less trees that suffer from this, but there's a labor piece in there that I'm thinking about to make sure that all the correct elements come in.
You're correct that the landscape in terms of where you might need to pull records for somebody who's come in through the emergency room, been admitted, gone through surgery, and then was on a med-surg floor as an inpatient for a week afterwards. You are absolutely right that there are going to be a number of different charting software systems that were employed during that hospitalization. So, from my experience from the lawyer side, we're always worried, are we getting the entire record? Yeah. Is there something being left out? And so we're asking, what software system is used in the OR? And when you pulled records, did you pull from those records in the OR? I will tell you that there are some providers who are better able to pull all the records together than others. And perhaps that has to do with how well their systems are integrated by whatever that database or software operating system is that pulls things from all different areas. So it's not uncomplicated, I agree, but I think that much of it has been automated because the hospital needs to pull all that information together for their own use. So a provider can see what happened in anesthesia during that surgery. The hospital needs to get it into the chart in a place where providers can access it. So they're already doing it to some extent. And there will be circumstances where something is missed. And in that case, if I'm doing my job, I'm trying to understand the whole picture of what happened to this person during that week from emergency room entry to discharge. Then I'm asking if there are any holes. But for the vast majority of records, the hospitals or providers are already doing their best to integrate all those diverse systems so that they can use them for purposes of providing competent health care because they need that communication.
And that, as you pointed out, may I just earlier with electronic medical records, as we were rolling into that and implementing it, one of the primary benefits of it was this relationship of the records being easily transferred to, a specialist could, instead of waiting for a whole stack I remember going down to the medical records, working the midnight shift and having to get that stack and then bring it back to the department. Thinking about that versus being able to click and have the entire file come in and or that part of the file from the primary care provider of why they were referred. I mean, that's, that was the beauty, or supposed to be the beauty of this. And in many places it works well, but there are these pieces, these outliers that have to be brought together to get the full record.
And this would provide them with an incentive to develop the systems to do that. I will say that I think all of us who practice in New Hampshire, whether we're doing medical malpractice work, personal injury work, have had a phenomenal experience with Dartmouth. When Dartmouth first went to electronic records and we started trying under HIPAA and the HITECH Act and Cures Act to obtain records from Dartmouth, and this guidance came down from HHS about charging a flat fee of $650 or the reasonable labor cost for producing that record, we brought that to Dartmouth's attention, and Dartmouth started doing it, and they do it for lawyers and patients for $6.50 without fail. And they will sometimes miss something, and we'll communicate with them and we work with them and they find it and they provide it to us, but they are able, and this is across the Dartmouth system. So you see this coming from Cheshire Medical Center and Dartmouth in Manchester. So it's certainly doable. They're doing it and they're not using these third-party services, to my knowledge, at all. They're doing it in-house.
Thank you.
Any other questions from the committee? Seeing none?
Thank you very much.
Maureen Menzie? Welcome.
Good morning. Thank you for allowing me to come here and speak today. I'm very excited to talk about this. My name is Maureen Menzie. I'm a vice president with Sharecare Health Data Services, a release of information service provider in New Hampshire and 46 other states. I am also here representing our trade association, AHIOS, and that stands for Association of Health Information Outsourcing Services, and all the member companies that also perform release of information services for hospitals and clinics in New Hampshire and beyond. I'm here to voice our opposition to the Senate Bill 400, and it calls to make the release of medical records free to requesters in the state of New Hampshire. This type of bill illustrates possibly a lack of understanding of the release of information process and assumes that releasing medical records electronically is little more than a push of a button, which Attorney Kirkland actually just mentioned in her her presentation. I'd like to share with you this record releasing process. Certainly is more than just pushing a button. So I'm going to walk you through not every step, but just to give you an idea of what our trained and certified people do when they're going through a record. Most of the steps involved in properly releasing medical record information are performed by our release of information trained specialists who understand the changing rules that govern patient privacy and as governed by HIPAA and numerous other state and federal regulations. We take our direction. In this business, I'm a vendor. There are many vendors out there. It was just mentioned, and SciOx is another in the area. So we all take our direction and are given guidance by Health and Human Services, the Office of Civil Rights. And then we follow all state statutes for charging for records. We follow the cost-based fee when charging patients. And patients also have the ability to go onto a medical record website for a hospital or a physician office to actually go into their chart electronically and ask for a copy. So they don't even have to come through a vendor or go through actually the site, the physician's office or the hospital. They can just go in, and it's very simple and very easy. I know that some people will struggle, so there's help for those folks, but all patients don't have to go through the process that was just outlined. There's different ways to get medical records. And I just want to stress, when we are releasing medical records to patients that are looking for records to themselves, they are only charged that cost-based fee. So we aren't charging third-party rates to patients, never have and never will. So moving on, once we have the authorized records, the team then reviews the record to make sure there are no misfiles. While we're not dealing with paper, I've been in the business for about 36 years, and I was there standing at copy machines, copying the paper. So we have evolved so incredibly, and things are easier, but that doesn't change our job. That doesn't change what we do, because when we get that request for medical records, we have to go into the EMR and potentially go to the fiche machine because there might be some microfilm, or go and pull the paper. So we have to marry all of that together. But what we're doing is making sure we're looking at that request, making sure what's been authorized to be released, we're releasing. We can't do less, we can't do more. If we do that, that's not a good thing. So our team is trained to look at what's been authorized, look at what the patient has actually signed off. There are many sensitive protected items in a record, so every one of the team members has to be reviewing the record as they're pulling the different pieces from the different EMRs and the paper. They need to make sure that none of the protected information, if it's not released, gets out. So as you know, there's many different protected areas that we have to look at in a record to make sure it's signed off before it can leave. So such as mental health, HIV, child and elder abuse, social worker notes, domestic violence, and the list goes on and on. So our team is trained to look for in each record, is there any sensitive information? Is there any misfile? Is there anything in that record that if we aren't validating every single page could potentially get out and cause a breach? So we take that very seriously. We go through every single page, 5 pages or 5,000, it doesn't matter to us. We are looking at every page, because in an electronic medical record, back in the day with paper, you would be going through a paper record, you'd see misfiles. That was kind of, I don't want to say common, but that was something that you would see because folks are just filing these records. Well, just because we've gone electronic doesn't mean there aren't any misfiles in a record. So when the team is going through, whether they pull it from the EMR or the paper, we have to check every single page because there are misfiles. So John Smith's record could be in Maureen Menzies' record, and we have to make sure we catch those, and we do a very good job of that. But that is part of the process. We have to make sure everything is validated in the record that's been requested, And if we find sensitive and it's not authorized, we need to stop right there and get the special authorization to release that protected information. So again, I just want to stress, there are so many pieces to processing a medical record. And I loved your story when you were talking about, pulling the different records together, because that's what we do. We have EMRs, fiche, paper. We have to pull everything together, look at the visit history, make sure everything's there before we release anything. And the team it takes a lot of time. This is not pushing a button. And the most important thing is the request starts the ball rolling. That's the life cycle of the release of information. So once we get that request, we go into the EMR, we see what we need to pull, we go through everything to make sure everything is there, and making sure everything is in that record before we release it. Our biggest commitment is to protect the patient and make sure that what we do release is valid and compliant. That's part of what our team does. So, and they take that very seriously. And there's a training that goes into, our team members. When they're hired, we have a very strict protocol of training, and they have to go through this training. And then, there's steps all along the way before we just let them start releasing, because we want to make sure they have all of the elements. They know what to look for. So, I just want to call attention to there's so many steps involved, and it's very much not just pushing a button. I actually, if someone said to me, you just push a button and let it go, I would respectfully say that concerns me, because we need to make sure anything that gets released is compliant, that we're not sending any patient information to anyone that it doesn't belong to, that hasn't been authorized. So there is time, commitment, training. This really, I can't stress, this isn't pushing a button. So when we arrived here today, I was able to see the amendment to the Senate Bill 400. Well, there are some good parts to it. It recognizes that a fee should be allowed, but I just hit my gut that $650 with a cap of $25 to do what we do day in and day out. And I know it's just it's just thrown out there now. It's certainly not something that I think more discussions have to be had on it. And I know that's what you all are probably gonna be doing next. But I was just surprised, because in New Hampshire, it's only 50 cents a page to release a record. It's 50 cents per page. So everything we're pulling, everything we're reviewing, everything we're validating, it's 50 cents per page. Remembering patients only get charged the cost-based fee, which is minimal. A 92-page record under a cost-based fee request, maybe $20. So if you're only looking for records that are maybe 10, 15 pages, the cost is minimal to a patient. But just also know that if a patient can't pay for their record, we're not going to say, we're holding these records till you pay us. That's just not what we do. And I'm speaking from the Sharecare side of things. But I just wanted to, and again, I just saw this amendment this morning when we came in. So I just wanted to give you an idea of what some of everything we do is regulated. The statutes are all regulated. So I wanted to share a couple statutes with your surrounding neighbors. So Massachusetts has a clerical fee of $28.38 and 95 cents a page. Maine has a $5 flat fee, but 45 cents a page with no cap. Rhode Island has a $25 clerical fee and 50 cents a page up to 100, and then it drops to 25 cents a page, but no cap. New Jersey, it's kind of a little bit further away, but $20 clerical fee, $1 a page for up to the first 100 pages, and then 25 cents a page. with no cap. I've been doing this, I think I already said, for 36 years. I honestly, New Hampshire has one of the lowest statutes. We work well in it. We haven't complained about it. We do our job, and we have never said, oh, we wish that was more, but maybe we do, but we've never said that. So we don't understand why this is being brought forward. And I guess that's part of this process, is to figure out what the intention is. But 50 cents a page for what we do and the care that we take, because this is what we're doing. Every request is, there's a patient behind it, and we have to make sure we're protecting those patients. And pushing a button, again, I would say that is not what this is about. If we want to protect those patients, we need to follow the process. And I only scratched the surface of what goes into what we do, because the list is long and I could provide it to you step by step. There's many, many steps involved in this. So I'm, not rocket science, I get it, but there's a lot to this, and we take it very seriously. In closing, I just wanted to say, if these regulations, if the cost changes, I'm not sure how we would be able to operate, but that's something, when this all settles, we'll have to weigh that. But this burden of releasing these records would have to go back to the providers, would have to go back to the hospitals. And today, that would be a huge burden to them. I mean, they have so many other things that, cost-wise, that they're trying to manage. To throw this back onto their lap, and they'd have to hire people to do this. They'd have to make sure they had the trained people. Our people are trained and certified in this. So that is a concern and a pause for me to think this would all go back to them, because they couldn't afford to subsidize what, this cost to keep us doing this. They don't have, that ability, that revenue sitting anywhere. So I am here today to oppose Senate Bill 400, and I just want to say thank you for allowing me to speak. I appreciate it.
Hey, Mark.
Thank you, and thank you for your testimony. It sheds a little extra light on the topic. One of the points of the previous speaker was that their paralegals are spending about 70% of their time helping individuals navigate the access. So can you talk about the ease of how you provide that, or why is it so difficult for individuals to get access, and it takes a paralegal to help them through that process?
Right. So I can't speak to, I heard what Attorney Kirkland had said their process is. Our process is, when we get a request for medical records from a patient, from a third party, anybody, that ends the piece, the responsibility on the requester side. So from the time we get that request, and they can mail it in, they can drop it off, that authorization. There's all different ways for us to get a medical record request. It's very simple and easy, and most of our clients today have an authorization on their website. So a lot of our customers, and we have many in the area, direct patients, direct third parties, go to our website, there's an authorization on there. And if you're not computer savvy, because we see that a lot, they can send us a letter. They can call us and say, I need my medical records. And we ask some questions, we have to do our due diligence. But there's all different ways to get medical records. But it first starts at that request has to be generated. So, but again, directing patients to a website, like if the covered entity, the hospital or the physician group, which many around here have the Epic EMR, there's a portal. They can go on to the website, click into the portal and say, I need my records. And they get their records right back in that portal. We do that. We fulfill those requests. That's not hard for anyone to do. But there's many, many different ways to send a medical record request, to get your records. And from where I sit, it's not something that's difficult. And if it is, we accept phone calls to help anybody navigate their way through it. Does that answer that?
Thank you for coming to testify. While I agree that there should be a cost to it, I have here a number of bills that were sent to the attorneys of some of the patients, and they range from $675 all the way to almost $3,000. Now, while it was requested by the attorneys, but these attorneys are working for the patients, are they being charged differently? And if so, the charge is going to be, they're going to charge the patients for that amount of money. So the patient is paying for it one way or the other. So does it really take $3,000 to get medical information?
So I think, let me just think for a moment how to respond. So $3,000 invoices, that would be a very large record. We don't, there are large records this amount, so it's all over the board what attorneys get charged. But if they give us the paperwork that they are the patient's legal representative, then they would get that cost-based fee. But there is a lot, and can I talk about, I don't know whose invoice that is, can I talk about, is what we do worth $3,000 depending on pages? Because we are going through, we're looking for all that sensitive. We're looking at every single page. Are there misfiles? You know, there's so much that goes into it. It doesn't just take a minute to pull together a record. You're looking at the visit history. Where are these records? So these are paper, these are fees, these are in the EMR. We call that a hybrid record. We pull it all together, and we're going through that and making sure every page is valid and compliant. So I don't know how to answer, is it worth $3,000? We charge by state statute, so we don't make up our fees. We follow the statute here in New Hampshire, which is 50 cents a page. So that record was a very large record. So did we spend a lot of time going through it, as I commit we do to everything? Yeah, it took us a long time to go through that. But we follow statute.
I have one, if I may.
One final question, because I got another bill.
Sure. Yes, thank you, Madam Chair. And, you must have your own expenses like insurance to cover in case there's a misplace. Is that significant? Meaning to cover yourself in case somebody sends a bad file and then there's a lawsuit on your hands.
So you're talking about our insurance in case there's a breach or, yes, I don't know off the top of my head what ours is. But yes, every one of us vendors out there have that insurance, liability insurance. Yep.
Questions from the committee? Seeing none? Thank you,
All
Maureen.
right, thank you so much. Have a good day.
You too. Happy Valentine's Day. Ben Bradley. Oh, you've changed.
Changed. Thank you for allowing me to be here in Ben's position. He had another hearing he had to attend. For the record, good morning, Madam Chair, members of the committee. My name is Kathy Bizarro-Thunberg. I'm the Executive Vice President at New Hampshire Hospital Association, representing all of our state's acute care and specialty hospitals throughout the state. The New Hampshire Hospital Association has concerns with Senate Bill 400. Our hospitals respond to medical record requests in compliance with both the Health Insurance Portability and Accountability Act, HIPAA, as well as state law outlined in RSA 332I. Our members either use staff within their organizations or may contract with a vendor, as you heard from the previous speaker, to provide medical records upon request. There are direct costs associated with staff responding to medical records requests, whether they're paper or electronic. There is no direct cost to hospitals that utilize a vendor because vendors charge the third parties directly for those record requests. Providing medical records can be costly and complex, as you heard, Medical records can be stored in multiple electronic systems, or could be a mix of paper and electronic. It could also be film, it could be paper that is scanned, and so forth. However, patient portals, which are secure websites offered by providers, conveniently give patients access to some of their medical records and make sharing of records with patients much easier. But we know that that doesn't always cover everyone's needs. Charges for copies of health information are typically applied when third parties, such as trial attorneys in malpractice cases, request medical records. HIPAA does not apply fee limitations to these types of requests since they don't originate from the individual. I did attach to my testimony several pieces of information from a federal HHS that covers specifically access to health information and copies of medical records, and how HIPAA looks at the patient's request versus their third-party request on their behalf, and how those fees get applied. So this really just tried to go into more detail for you on the federal side, how that is applied. So I hope you find that helpful, and it also goes into how state laws interact with HIPAA. If Senate Bill 400 became law, hospitals provide this service in-house would not be able to charge for providing an electronic copy of medical records for any requests, whether from individuals or third parties, and the existing fee structure would be reduced for paper copies. Additionally, the business model used by hospitals that have a vendor relationship would be disrupted because the vendor could no longer be able to charge for electronic medical records and would not find New Hampshire business being able to do business in the state. We have concerns that this would deter the vendors from doing business here, forcing our members to provide this service in-house without compensation. And as the previous speaker noted, we would have to then find those specialized staff to do that work when they really already have a hard time finding staff as it is. Alternatively, vendors would seek payment from hospitals to provide medical records for their patients, adding costs to hospital operations. I also wanted to add to my testimony that we talked to our specialists, the health information management folks who do this work day in and day out. Most of them, if not all of them, if a patient contacts them directly, will give patients a copy for free. What we have found is that some attorneys know this and ask their patients to call the hospital on their behalf to get their free copy. So we already do a lot of free copies for patients, despite the fact that we could charge patients and or their attorneys for it. We know this business happens, but we're doing it because we think it's the right thing to do for patients, because we want to make sure they have access to their information. But at the same time, there is a lot of requests for medical records that have nothing to do with patient access to information for their own information. It's for other reasons, such as you mentioned, from attorneys. And so there are costs associated with that. And as the previous speaker noted, there's a lot of specialty work that has to go into play to review those medical records to make sure that it's accurate, to make sure that what was requested is only is what is released. And that takes time, and it takes effort, and it takes the special knowledge to be able to do that. So in the end, for these reasons, we cannot support Senate Bill 400. Be happy to answer any questions.
Thank you. Any questions?
Thank you. Thank you, Madam Chair. You're sort of making a distinction from when the individuals ask it for, compared to, for example, like with an attorney ask it. But when an attorney asks for it, it's on behalf of a patient, and they're not asking it without the patient's permission. And so it's hard for me to sort of understand the distinction, because they're asking for it at the permission and at the request of the actual patient. So it's hard for me to see that distinction, if you want to help me understand that.
So typically for a patient, they are using it for their own use. For an attorney, they may be a lot of times asking birth to death. And so, as someone mentioned, there could be, really large records. And they're looking for lots of information. So that takes a lot of time and effort where a patient may be looking for something that happened to them last week, which is very different. So I think it really comes down to the purpose. And when the service is meant for the individual, that's where the hospital really wants to focus, is on the individual.
My watch keeps telling me to stand, to stand up. I'm like, okay, I'll get there. Hi, thank you for taking my question. So this is about consent. So I heard from the person who testified before you, was it Maureen? Okay, there is a reason I write down names, but then my handwriting is terrible. So talking about consent, Kathy, when there's it strikes me there's a consent involved with the release of very specific records, and examples were given. So do the hospitals in New Hampshire, and I have a universal process that they use when a record is requested, regardless of who requests it, that specifies those?
Absolutely.
Okay.
Yes, there is a very specific requirements under HIPAA that dictate what an authorization looks like. And there are forms that each hospital use that a patient needs to check off. It's okay to release my HIV, or it's okay to release my domestic violence, or it's okay to release my medications, my mental health records, or they don't check any of those. And so that's where the person who's reviewing that request for information goes through and said, okay, the patient said, I can't release any of these sensitive things. So they have to redact or make sure that those components are not on there. So it is dictated by HIPAA how those authorization forms are structured.
Okay, great. Thank you. I just wanted to be clear.
So just one more clarifying question. You're not saying that there should be different charges for the records depending on the purpose of the use, right?
HIPAA does allow for a different differentiation between the patient need and third parties. And so under HIPAA, reasonable costs, and there's a whole definition, and I included that in my testimony about what is considered reasonable cost that could be charged to the patient. As I mentioned, even hospitals here just do a free copy to patients because they think that's the right thing to do. But if there are other reasons for access to medical records, HIPAA has said that the reasonable cost does not apply. When that doesn't happen, then it falls to state law. And as the previous speaker said, they follow state law as well as the hospitals do on what that cost structure is in current law.
Follow up. So I'm not sure you answered my question, but so let me put a finer point on it. Say I request a record for the purpose of litigation versus when my attorney asks for it for the purposes of litigation. So are you saying that the cost that should be charged really does depend on the purpose? I mean, I hear what you're saying about HIPAA rules. I understand that clearly. But what I am sort of hearing is that you feel like there should be a charge depending on the purpose.
So the hospitals do not ask patients what their reason for asking for a record is. But clearly when it comes from somebody else representing the patient, there's the reason behind it because the patient has signed off on that authorization. So when the patient does their own requests, the hospital can say, well, is this for litigation, or is this for just your own, pleasure reading? They don't ask for that at all. That is not something that is necessary when a patient requests it.
Any other questions from the committee? Seeing none, thank you.
Thank you.
Last speaker on this bill is Nick Abramson. Before you start, Nick, also, I just want to let everyone know we have one more bill after this, so. Go ahead.
Thank you, Senator. And I'm one of the few lawyers who doesn't like to hear himself talk, so I'll try to keep this pretty brief. Madam Chair, the remaining members of the committee, thank you very much for taking the time to hear us this morning. My name is Nick Abramson. I'm a lawyer at the law firm of Abramson, Brown & Dugan in Manchester, New Hampshire. I specialize in representing plaintiffs in medical negligence cases. And formerly, I was a federal prosecutor at the U.S. Attorney's Office here in Concord, where I specialized in child sex trafficking and child sex abuse cases. So I've dedicated my career to representing victims, both criminally and civilly. And I think it's critical here that we view this bill for what it is, which is a patient advocacy bill, not an attorney advocacy bill. And I think Senator Birdsell and Whitley, you have your finger on it on the issue, which is what is the distinction that we're trying to make here between a patient and an attorney requesting these records? And I haven't heard a good answer to that question of why we would charge more for a lawyer to get records on behalf of a patient than the patient directly. I mean, that's really the nub of this. And I think we all know what the answer is that the view by the providers is, number one, that there's some nefarious undercurrent to a patient wanting to explore whether they were harmed by negligent medical care, and that they should be essentially punished for that by being charged more for their records. And number two, that lawyers have deep pockets, that a patient might not be able to pay for the records, but the lawyers can. And I think the fallacy with that and the big problem is, as you mentioned, Senator Birdsell, that these costs do get passed to the patient if there is a recovery in the case. So, the patient is the one being harmed here, not the lawyer. Now, we as the lawyers assume those costs if there is no case or if there is no recovery. We don't pass those on to the patient. We pay for those out of our pocket. But if there is a recovery in a medical negligence case, those costs of getting all those records, which can be many thousands of dollars, come out of that recovery. So we're really, because it's a lawyer requesting it rather than the patient, we're just taking more money out of that patient's pocket for no discernible reason. So I think that's the first point in response to some of the opposition testimony I've heard is I don't hear any good reason for that distinction. Number two, I would say, just as an overarching consideration, how can Dartmouth do it? We're sitting here talking about all the ways that all of these different providers are unable to efficiently provide these medical records to patients and their counsel. I can tell you we have handled dozens and dozens and dozens of cases with Dartmouth Hitchcock Medical Center as a defendant. Without fail, in every single case, they are able to efficiently and completely provide their medical records to us for a very low cost, for $6.50. No issues, no complaints from them. They just do it. So if Dartmouth can do it, why is a specialized third-party vendor whose sole purpose is to provide these records in these kinds of formats unable to create the kind of system that Dartmouth can to be able to handle that? So those are the two big considerations I would urge you to think about. My role, though, here today primarily, and I'll try to keep this very short and sweet, is to give you a sense of what this looks like procedurally on the ground. As a lawyer who's representing these patients and getting these records, what is happening and what we're seeing. So the way I would try to frame it for you is to give you a specific case, which is a very common kind of case that we see as a medical malpractice lawyer, which is a failure to diagnose cancer. So we see this all the time, and I'm handling several cases right now where you have a provider who is reading some kind of imaging, they fail to identify a malignant lesion, years go by, and then incidentally that client is diagnosed, that patient is diagnosed with cancer, and that delay has now resulted in an upstaging of their cancer, a significantly worse prognosis, and by the time they get to me, they're going through chemotherapy, radiation treatment, surgical resection of metastatic disease. They are not in good shape. So this idea that plaintiffs who want to explore whether they might have a viable claim for medical negligence that has put them in these circumstances, in many cases, and I would say the overwhelming majority of our cases, our clients are not feasibly, realistically in a position to try to go on some portal and navigate getting their records and talking to the representatives of the facilities or the third-party vendors to try to follow up on these things. I don't think it's reasonable for me to put that burden on my client who's getting chemotherapy every week and is living through hell to try to take on that process for themselves. That's my job, and I'm supposed to be representing them, and I don't see any reason that we shouldn't be able to do that. So that's a very common case, a very common scenario, why I don't think we can simply say, well, let's just shove it on the patient, because that's not how it should work. So then what do? We request these records directly as the attorney. We send out the requests. One thing I do want to note is that in almost all of our requests, we very specifically state that we want sensitive information. We want the complete record. We don't want redactions. So this whole idea in these types of cases and claims of these vendors having to go through page by page and line by line to redact sensitive personal information. We don't ask for that and we don't want it. So it shouldn't be part of the cost calculus in terms of getting these records. So we send in these requests, and I'll explain to you what we get back. And this is not the exception to the rule. This is what we see. And I can honestly tell you almost every single case, we get a single PDF that is thousands of pages long of disorganized, non-searchable, duplicative records. So there's no tabulation, there's no organization, they're not chronologically ordered. You can't do a Control F to search the document. It might be 3,000 or 4,000 or 5,000 pages, of which 10 to 20% of it is actual original records versus completely duplicative medical records. They're often incomplete, which results in us having to make follow-up repeat requests to the facilities and the vendors. And then what we see is we get records back that are, it's not just that we get the missing pieces, they're inconsistent. So it's almost like a new set of records where you have some stuff missing and some new stuff. So we'll have cases where we have to make 3, 4, 5 requests just to feel confident that we have a set of records. And we get charged routinely, as you mentioned, $500, $700, $1,200, $1,500 for this. So I hear a lot of discussion in the opposition testimony about all of these steps that are taken to provide these records. But what I can tell you is, not that I think there's ever a justification for a patient being charged hundreds and hundreds of dollars, but we certainly aren't seeing that charge reflected in the product. Obviously we are not behind the curtain to see what's happening at these third-party vendors, but what I can tell you is the product we are getting is not commensurate with a $500 or $1,000 or a $1,500 fee. It's a 5,000 page PDF that we then have to go through, deduplicate, organize chronologically, and figure out what's missing so we can send follow-up requests. One other issue that we've tried to address with the proposed language in the bill is that it often takes many months for us to get this product. So as it stands under the law, we should be able to get these records within 30 days for our patients. We often have to send reminder letters to the vendors or the facilities to get the records. It can take 2, 3, 4 months to get the records, and sometimes we don't get them until we actually send a letter threatening to sue the facility or the vendor because they're failing to provide the records. So that's a common issue that we've tried to incorporate language to ensure that the patients are able to get them in a timely fashion. And then finally, if we get a case into suit, if we get the records and determine that there is a valid claim, what we see in many, many cases is that in the process of discovery, the defense lawyer will then provide us with a copy of the records, and we see a whole bunch of new records that we've never seen before. So we've gone through this whole process, paid all this money, gone through all these efforts to try to get a consolidated, organized collection of complete records, only to find that the hospital has handed the defense attorney a set of records that is twice as voluminous and complete and organized. So I don't understand how that process works, but to me it seems to undermine the idea that this is some unattainable task for the providers because the defense lawyers have it at their fingertips. And we see that in many of our cases. So I'll just give you one specific example of a case that my colleague Holly Haynes and I recently had where we had these issues where it's an active case. We had to make 4 separate record requests to the third-party vendor. We got 4 very different sets of records after each request that totaled maybe 2,000 pages. We finally got the case into suit. We go through discovery, and lo and behold, we receive, actually accidentally in the wrong case, the lawyer sent me 10,000 pages of records from the hospital, much of which was duplicative, but a significantly larger record than we had received after 4 requests before we got the case into suit. So that's just one example, but it happens routinely. The reality is, and we would never do this because this isn't how we practice, but given the amount of the bills that we see and the costs associated with obtaining these records, it would be cheaper for us to just file suit in every single case and get the records for free pursuant to the civil discovery rules. We're entitled to that. So where we're seeing bills for $500, $1,000, $1,500, it would be cheaper for us before even looking at the records to just file a lawsuit and then demand the discovery from the defense and get the records and get a complete record and then see what's in there. Now, that's not something I would advocate for. I don't think that's the right way to do business. I don't think that's the right way to review a case. But when you look at the way the system is currently structured, the financial incentives are so wonky that that would actually make sense to a patient and a client. So from our perspective, there's really just no justifiable basis for these costs. There's no justifiable basis for there to be a distinction between lawyers requesting them versus patients. And we've seen time and again that facilities like Dartmouth and others in litigation are able to do this. So we don't understand why these kinds of fees are necessary. So I thank you for your time. I'm happy to take any questions.
Thank you, Nick. Any questions from the committee?
Sure.
Thank you for taking my question. I'm sorry I missed part of your testimony, but as you concluded, when you said there's no justifiable, it's not justifiable for these costs, you mean the electronic record? That there's no justification for having any costs related to that? Is that?
So I think what I'm...
And I missed the first part, so I apologize.
No, that's okay. I think I can simplify it. So I think what it comes down to for me, I think there are a number of ways that they're not justifiable, but primarily it's this distinction that I think is an arbitrary distinction between the patient requesting and the lawyer requesting. And so what's the justification for charging a lawyer $1,500 if you're going to charge a patient $6.50? And I think the justifications that exist are not valid. There just is no basis to do that. So all of this discussion about the 200 steps that are taken behind the curtain at these third-party vendors, well, they charge the patient $6.50. Why are they charging the lawyer $1,200? I don't understand that.
Okay, thank you.
Sure.
Any other questions from the committee? Seeing none.
Thank you very
Nick.
much for your time.
Is there anyone here that would like to speak on 400 but hasn't been given the opportunity? With that, I will close the hearing. I will recommend highly that, I know there's a distinction between the two. Try and work as best as you can together to get it, because I want something passing. So, thank you. And when Cam is ready, we will open the hearing for 402. Is it 402?
No, I still think everything's careful. Okay, so we're going to open up the hearing for SB 402 and hear from the prime sponsor, Senator Bertzel. You are now recognized. And before we go any further, I just want to let everybody know we're on a time constraint. So anybody who's testifying, I'm going to ask you, please, 3 minutes at the most, just because we're running out of time. So thank you with that. Senator, you are recognized.
Thank you, Mr. Chair. Thank you, committee. For the record, my name is Regina Bertzel, State Senator for District 19, which encompasses the towns of Derry, Hampstead, and Windham. And I'm the prime sponsor of Senate Bill 402. I had a tough time figuring out why I had sponsored this. And luckily, Cam reminded me that last year we were listening to Senator Rosenwald's bill, pulled it out, and I had promised to put this in for her. Here we are. basically what this bill does, there is an amendment, it's Amendment 0692, in speaking with Beth Sargent, who they had asked to put in an amendment. Basically, if you looking at the bill itself, we added back in the language on lines 4 through 7, a pharmacist, pharmacy intern, licensed advanced pharmacy technician, or certified pharmacy technician under the supervision of an on-site immunizing pharmacist may administer, we added this back in, influenza and a COVID-19 vaccine if available to the general public. A pharmacist, pharmacy intern, or licensed advanced pharmacy technician under the supervision of an on-site immunizing pharmacist may administer, and then we continue with the rest of the information. Basically, what this does is allows the pharmacists to, as long as it's an FDA-approved vaccine, to continue giving the vaccines without having to come back each time to the legislature to get it approved. That's basically what this was intended to do. And with that, I'll take any questions.
Thank you, Senator. Any questions from the committee? Seeing none.
Thank you.
We are going to ask Ryan from DHHS to step up. You're next. Yeah, after you're speaking, right?
Good morning, Madam Chair, members of the committee. I'm Ryan Tanyan, the Bureau Chief for the Bureau of Infectious Disease Control at the Division of Public Health Services. In full disclosure, I'm also a registered pharmacist here in the state of New Hampshire. Initially, we had signed in to oppose Senate Bill 402 prior to the amendment, as we had some concerns removing the provision for allowing COVID and influenza to be administered by pharmacists to the general public, as we believe that this would have had an impact on those under the age of 18. However, we're here just to answer any questions, as the New Hampshire Immunizations Program falls under our Bureau, and provide any information that the committee may have.
So the department is fine with the bill as amended, with this amendment?
Right now, the department's remaining neutral on the bill, but initially we had been opposed to it.
Any other questions from the committee? Just an FYI for everyone, it doesn't look like we're going to have time to exec anything today, because I'm losing my senators. Well, Senator Bradley left ours. Any other questions from the committee? Seeing none, thank you.
Thank you.
Ava.
Good afternoon, Madam Chair, members of the committee. Out of respect for the Vice Chair's request for brevity, I will just say we signed in opposed to the bill prior to knowing about the amendment Senator Birdsall mentioned in her introduction of the bill. The reason we were signing in opposed was chiefly to address the concerns we have about access to the flu and COVID-19 vaccines for children in our state, and allowing pharmacists to provide those. But it sounds like this amendment that is in drafting or has been drafted would address those concerns, and we look forward to looking that over. Thank you. Happy to take any questions.
Any questions from the committee?
Thanks.
Thank you, Ava. Beth. Absolutely. Okay.
Good afternoon, Senator Birdsall, members of the committee. My name is Elizabeth Sargent. I work for Champaign Capital Group here in Concord. Here today representing the New Hampshire Society of Health System Pharmacists. And Tanya.
Good afternoon. My name is Tanya Carlton. I'm a licensed pharmacist, as well as the president of the NHSHP, the New Hampshire Society of Health System Pharmacists, and also speaking as representation for Dartmouth Health System as well.
Senator Bertzel, we just had an opportunity to look at the amendment. Thank you so much for putting it in. It is exactly what we asked for, that it will bring back the pharmacists are currently allowed to give COVID and influenza. We just took a quick peek. There is one mistake. So I wasn't going to hand out my draft that I sent to you. What got left in, it is still crossed off influenza and a COVID-19 vaccine if available. So just a quick tweak to that, but we would.
Where's that? Look.
In the amendment on line 12, it starts on the end of line 11.
Okay.
So influenza and a COVID-19 vaccine if available to the general public, if we could ask if that be put back in.
Okay.
So I just handed around the version that I sent you, if that's helpful.
Okay. That's too bad. All right. I will get that redrafted.
Thank you, we appreciate it. So we are testifying in support with an amendment.
Great. Thank you.
And Tanya's here with me if anyone had any questions about pharmacist administering.
Questions from the committee?
Thank you so much.
Thank you. The last speaker on this is Courtney Tanner. Okay. All righty then. Okay. All right, is there anyone here? That was the last speaker. Is there anyone here that would like to speak on Senate Bill 402? Yes, come on down.
Just quickly, for the record, my name is Kate Fry. I'm Vice President of Advocacy. We had signed in opposed previous to the amendment too, and we are neutral, but I do want to make a note that the amendment that was handed out is not quite where we need to be. Again, as just echoing what Beth said, if adding in influenza and a COVID-19 vaccine, then we should be good. And we appreciate your support and your work on this bill. Thank you.
Any questions? No? All right. Is there anyone here that would, anyone here else that would like to speak on Senate Bill 402 but wasn't given the opportunity? Come on down.
Good morning. I'm Abby Rogers, Legislative Liaison for the Division of Public Health. I know we just talked about this, but I just wanted to be clear that we provided testimony that we supported this amendment. We also have, I know it's going to be fixed in subsequent ones, but the issue of the strikeout of influenza and COVID-19 vaccine. So that would be an issue for us. So if that was fixed in an amendment, we certainly would support, be neutral on that. Thank you.
Thank you, Cam. Senator Bertzel for, it's my 557, prohibiting, Senate Bill 557, prohibiting discriminatory actions related to the participation in the federal 340 drug pricing program. Do we have a timeline? Because that's, do we have a timeline when we can do that?
This is not an FN, so.
So the deadline for all bills to be out of committee is April the 4th.
So I was hoping to get everything for, we only have 4 bills left.
Okay.
So I was hoping to get all of them done next week.
Okay.
The last 4. I was hoping to get all 4 done and heard next week, so we're done all of our hearings, and then we, and maybe exec a few more, but if you need more time on that?
No, I just wanted, I'm bringing in some advocates
Oh,
and I
okay.
need to make them aware what the schedule is. So I'm good on timing
Okay.
in terms of, it's just about preparation and getting the right group here.
Yeah, we only have 4 bills left next week, and then.
likely next week. So 557, you think we can schedule for next week?
Yeah.
Yeah, okay.
And then we'll do exec as many as we can before we leave for break.
Okay.
Okay?
Thank you very much.
Yep.
And then Kate Lippman appears. All right.
When we're all done, she appears.